the orbital apex, like on multiple locations, orbital apex, cavernous sinus, subarachnoid space, vesicle, or the nucleus itself. It can be affected by demyelinating process, vasculopath, as diabetes, hypertension, compression, etc. And then we have the neuromuscular process, the classical example, or the neuromuscular junction. The classical example is myasthenia gravis, and then it can be supranuclear, as in INO and stroke. So we have to ask ourselves what important historical and physical examination pieces of data that we'll need to acquire to fit the presentation into one of those boxes that we saw earlier, and then to formulate somehow a differential diagnosis. So first question is about the timing of onset and symptoms. Was it really abrupt, or was it more of a gradual process? So a truly sudden onset diplopia would suggest an ischemic cause, especially if it's maximum at the onset. Fluctuation, however, suggests a neuromuscular process, or it can be a TIA. And then the direction of diplopia, so mainly the gaze, was it on the lateral, was it the medial side? And then orientation, asking the patient, do you see vertical diplopia, or do you see images above each other or next to each other in horizontal diplopia? And then near versus far, it could be a quite good differentiating a piece of data as we will see earlier. And then a simple question, is it painful or not? If it's painful, it suggests an inflammatory or an infectious process. And then other associated symptoms, ptosis, headache, weakness, etc. Speaking of the physical exam, it's very important to do a thorough neurological exam, especially cranial nerves and gaze movement. This is probably, this is from Rosen here. As you can see, this picture about extraocular movement. All of us are familiar with, but it's important to keep in mind that each muscle can usually have more than one action. But there is one action that predominates the rest of the actions, which is as depicted here. A good mnemonic is SO4 LR6, which stands for superior oblique 4, which is the trochlear nerve. Lateral rectus is the 6th nerve, and the rest is the 3rd nerve, which is the oculomotor. For example, just to get a sense, so if there is a 6th nerve palsy affecting the lateral rectus, the patient will have horizontal diplopia looking on the direction that's affected. So let's say if it's affecting the right eye, the patient will have diplopia looking to the right. And then also in the physical exam, it's important to do the H configuration, because there might be subtlety that can't be detected except we do quite a meticulous exam. All right. Continuing physical exam. So eye inspection, ptosis, lead lag, proptosis. For example, this can lead lag proptosis can go with multiple processes. One of the classic examples is Graves' disease. Pupils, if they are symmetrical or not, reactivity to light, and then the Hens exam in the right context when we are concerned about a posterior circulation stroke. So we'll start with the first entity, which is mechanical orbitopathy. So so as we mentioned, there is this quite structural restriction of a single eye that can't move well. The history suggested for that is usually a gradual rather than an abrupt onset. It can involve single or multiple directions of gaze. It's usually painful. If there is a history of fever, of course, think about an infectious etiology. If it's worse in the morning, think about Graves' myopathy, which is the classical worse in the morning. And then usually the patient will have a proptosis, periorbital swelling, conjunctival hyperemia, or edema. And then for the cranial nerves, 3, 4, 6. So third, as we saw earlier, it supplies almost all the direction except 2. So the patient will complain of diplopia, usually in all or can present in all directions except the lateral gaze, which is affected by the 6th nerve. The 4th nerve is not that common, and sometimes it's quite difficult to diagnose. But basically, the main complaint is a difficulty with near an adduction. So a classical thing is reading a book or descending over the stairs. And then the sixth nerve is also lateral gaze onto one direction, as we saw earlier. If we see a combination of extraocular movement involvement that suggests more than one nerve, we have to think about areas where those nerves run together. So orbital apex, cavernous sinus, or the brainstem. But if it's involving the brainstem, usually we would see other findings as weakness, so some other significant finding. However, to keep in mind, myasthenia gravis is a mimicker here and can present with what appears as multiple cranial nerve involvement. Here we can see the orbital apex. So as we can see how the nerves are running close to each other here. So if we would imagine if there is a tumor here, it's likely to involve more than one nerve. This is the cavernous sinus, and the same applies here. The cavernous sinus is depicted in blue here, so we can see the third, fourth, and sixth are running in a close proximity. So we would expect more than one nerve to be involved. There is an entity called orbital apex syndrome. If it happens at the cavernous sinus, we'll have multiple cranial nerve involvement, but not the optic nerve. While if it's affecting the orbital apex, or it happens at the orbital apex itself, we would expect multiple cranial nerves as the cavernous sinus, but on top of that, optic nerve involvement, which present as a decrease in visual acuity, and a V1 involvement from the trigeminal nerve. Because the V1 is running also at close proximity here at the orbital apex. Okay. The bottom line from this slide and what we mentioned earlier, there are multiple cranial nerve involvement things where they run together. Orbital apex, cavernous sinus, and if there is any limb involvement, think about the brainstem. Okay, so we'll first talk about the oculomotor nerve, or the third nerve. It can be affected anywhere from the orbit up to the nucleus. The classical presentation, diplopia in all directions, the patient can complain from a horizontal or vertical diplopia. This is the classical teaching, down and out. But keep in mind, this happens only with a complete oculomotor palsy. So if it's incomplete, they would have more subtle presentations. And again, the pupil dilation here only happen if it's affecting the parasympathetic nerve or parasympathetic fibers, and we'll talk more about this in the next slides. So if it's affecting the nucleus, often the findings are bilateral. Ischemia is the most common. It makes sense because at the nucleus, they are next to each other in the brainstem. If it's involving the fascicles, it would present with the lacunar stroke syndromes, Weber, Benedict Cloud. I don't think it's important to know the details here, but rather to know that a third nerve palsy plus something equals, in many situations, equals brainstem stroke. And there are crossed findings, so cranial nerve involvement on one side, limb involvement on the other side, which is a classical for a brainstem finding. All right, and then in the subarachnoid space, so we'll ignore the isolated fixed dilated pupil because it's quite very rare. But there are two big entities here. If it's involving the pupils, which is like dilated pupils or different in size, or there is a ptosis. So it's an aneurysmal cause. Most likely or most common in the junction between the internal carotid and the posterior communication artery, the PCOM junction. And then if there is a pupillary sparing, which is quite the most common presentation, they will have a microangiopathic being the cause, diabetes, hypertension. And it's classically taught as well that if the second entity, which is the microangiopathic caused by diabetes or hypertension, patients have some discomfort. However, keep in mind this discomfort or pain by itself is not reliable to distinguish between the two. Okay. So probably most of us studied this at medical school. The classical teaching that says if the pupils are blown, it's compressive etiology as caused by an aneurysm. And that's because the parasympathetic fibers, which control the pupils, run on the outer portion of the nerve. So if there is an ischemic insult, which is diabetes in our example, it will affect the central portion of the nerve, and thus it will spur the pupils. However, if there is an aneurysm compressing over the nerve where the parasympathetic fibers are running, it will result on a dilated pupil. However, up to 1/3 of patients with ischemia, which is a relatively benign etiology, can present with the pupillary involvement, but at the same time, aneurysms can initially spur the pupils. So as we can see here, we can imagine if there is an aneurysm in this area, how it will push against the cranial nerve, and then we'll have the finding. Just keep in mind, because its presentations are not always typical, how missing such thing can result in catastrophic outcome. And in fact, there was a study published in 2017 looked specifically into this, and they found 36% of compressive, which is an aneurysm, serious problem. Third nerve pulses were pupil sparing, which is not the expected. And in general, 6% of all acute third nerve palsy will have aneurysm as an etiology. So as a result, although this goes against what Rosen suggests, so in Rosen, the suggestion was if it's the typical patient, let's say more than 50, 60 years old with diabetes, hypertension, present with a complete pupil sparing palsy, not to do an imaging initially. But more than one source suggests that to do a CTA for all acute third nerve palsy looking for an aneurysm. Keeping in mind that most likely in the patient above 50 or 60 years old with risk factor will not have an aneurysm. But it's a quite serious problem that we don't want to miss. Okay. The fourth nerve, again, it can be affected at any place from the orbit until the nucleus. Usually difficulty with descending cell reading. Diplopia is vertical, sometimes it's oblique. The most common etiology is congenital, and what happens is congenital, and then when the patient gets older, they decompensate and then they have diplopia. Trauma is the second most common cause, and then microangiopathic as diabetes and hypertension. It's quite difficult to diagnose if it's an isolated fourth cranial nerve palsy. It's quite difficult to diagnose. However, it's likely okay to be missed initially because the causes are not usually serious. So if it's an isolated, the yield of a CT is very low. You can refer the patient to ophthalmology or neurology, depending on the hospital's policy and the presentation. And they can do an imaging and non-urgent basis. However, the isolated sixth nerve palsy, which is the most common presentation, 50% of isolated cranial nerves will be the sixth nerve. At rest, there is often an inward deviation of the affected eye, like esotropia. And keep in mind, because the sixth supply the lateral rectus. So if we lose the lateral rectus muscle, which is responsible of looking laterally, there is expected at rest to be some minimal inward deviation. A patient will have horizontal diplopia, worse looking far, and to the affected side, of course. Again, microangiopathic causes is the most common. Referral to neurology as an urgent basis, let's say, is reasonable for the typical patient. By the typical patient, more than 50 or 60 years old with a typical risk factor, mild discomfort that goes with a microangiopathic process, and they have a completely benign exam. If it's not typical, usually the patient will need an MRI. If there's a history of a trauma, it's a different story. They will need CT because it's associated with a petrous apex fracture. Again, similar to what we saw earlier with the third nerve, they can be part of lacunar strokes syndromes or brainstem stroke syndromes. Again, it's not necessarily that's important to memorize those, but rather to know that sick nerve palsy plus something equals badness in the brainstem, including the 1.5 syndrome. Also, the sick nerve can be affected with an increased ICP. Those patients often have papilloedema, with their intracranial mass, dural-sinus thrombosis, or even idiopathic intracranial hypertension. So those patients usually have papilloedema. So the question would be how confident you are in doing fundoscopy. I'm not that confident in doing this. So it's reasonable with a reassuring exam is to refer to ophthalmology to be seen shortly in a couple of days to be sure that we are not missing anything serious. The same applies to, especially to idiopathic intracranial hypertension. So usually female and the age of 30s or 40s, because also if you do imaging CT scan, it might miss papilloedema and it might not show the classical finding. So, however, if it's bilateral, it's associated with more serious etiology like subdural hematoma, intracranial mass, etc. So those patients will need imaging urgently. So putting it together, so if you have horizontal diplopia, so diplopia will be greatest on the direction of the weak muscle. So we'll ask which side is the worst. So let's say looking right is worse. So it's either the lateral rectus on the right side or the medial rectus on the left side. And then you will ask, is it worse looking far or looking near? So if it's far, it's the sixth nerve. If it's near, it's the medial rectus on the other side, which representing partial oculomotor nerve palsy. However, with vertical diplopia, history by itself, it's not necessarily will give the diagnosis, but we will know with the vertical diplopia is either the third or the fourth cranial nerve. Generally, with the third nerve, you will expect to see some other signs as ptosis, pupil involvement, while on the fourth, usually, again, as we mentioned earlier, going downstairs, anything that involves near and a deduction will cause the symptoms. All right. And then the last entity is the supranuclear gaze problems. INO is the classical example, which is usually there is an MLF lesion. So here there is a problem on the right side, which is the side with the MLF involvement. So basically there is an absent A deduction on the affected side, and the other side will try to compensate by having nystagmus when it's going to the AB duction. This happens if it's complete. If it's partial, it will be more subtle. Classical presentation for MS in the younger population and a stroke for the older population. Basilar occlusion, that's a serious, really serious etiology that can present with diplopia. So always think about the other posterior circulation stroke symptoms: nystagmus, dysmetria, gait ataxia, and dysarthria. And those patients will typically have a vertical diplopia. Other myasthenia gravis. So if it doesn't fit a certain pattern, especially with multiple extraocular muscle palsies, think about this diagnosis. Usually the patient will have unilateral or bilateral ptosis. Classically, there is a history of fatigability and worsen at the end of the day. And the patient will have normal reflexes and no sensory abnormalities. The ICE test is a classical to examine for ptosis, which resolve with ICE, which suggests myasthenia, and then fatigability on sustained gaze. Graves' disease can present in a similar pattern. Vertical diplopia worse in the morning. Usually the patient have a history of hyperthyroidism. However, if the patient is complaining of worsening visual acuity, do CT orbits to assess for muscle enlargement or the optic nerve status. Others, Wernicke encephalopathy, which is the triad of nystagmus, altered mental status, and ataxia. Patients usually have ophthalmoplegia from the sixth nerve, as a pattern as a sixth nerve pattern. The classical patient would be alcoholic or has a history of malnutrition. Treatment is thiamine. Miller-Fisher syndrome. So it's one of the variants of GPS. Again, a triad of ophthalmoplegia, ataxia, and areflexia. However, if there is any history of muscle weakness or on exam there is muscle weakness, it is considered the GPS rather than Miller-Fisher. And then botulism, again, multiple cranial nerve followed by descending paralysis. This is not mentioned in Rosen, GCA. So it's not that common as a cause of diplopia. However, it can be transient. So if a patient presents at the right age group, above 6 years old, with a history of transient diplopia or diplopia on the last month, consider this diagnosis and rule it out. So at least do screening, CBC, ESR, and CRP in all of these patients. Because it has a catastrophic outcome. So keep this in mind. Those schedules are from Rosen. So I always like to think about it. Is it, yes, we know the pathophysiology, we have to do a proper exam, sometimes it takes time. So is it something that I have to act on it now, at the moment, or I have some time to think, ask a friend, check up to date, whatever. So I think some entities are really serious and we have to roll it out very early. And being the basilar artery thrombosis is one of the major causes because those patients progress so fast and there are not necessarily proven interventions, but there are interventions with a good outcome so far. So I'm talking about the thrombectomy. So if it crosses your mind, do immediate CTA, diagnose it, and refer as appropriately, and then also stroke because there is a time limit. So think about stroke. Other causes, if there is basilar meningitis, there is history of fever. Aneurysm, yeah, it's critical diagnosis, but you have some time to think about. Other causes, again, vertebral dissection, myasthenia gravis, we went over those. And those are less serious, a little bit urgent to be diagnosed. Okay, as a conclusion, so binocular diplopia is relatively rare in the ED. It represents 0.1% of all presentations, but can be the presenting complaint for many non-benign etiologies. So address the complaint. Cranial nerve palsy can be partial or difficult to examine. So if the patient tells you that there is diplopia, when you cover one eye, it resolves. So trust that there is diplopia even with a normal exam because it can be partial and difficult to diagnose unless you do more, you look for more subtle findings. Do CTA for all third cranial nerve palsy regardless of pupillary involvement. GCA can present with transient diplopia. Think about it or roll it out in the right age population. And then posterior circulation stroke results in high morbidity and mortality. So always think about it when the patient have diplopia, dysphagia, etc. And that's it. And if there is any question.
Great, thank you, Mansoor. It doesn't look like we have any questions. Okay, awesome. So we have Laurie speaking next about Glidescope intubations. So Laurie, whenever you're free, just share your screen.
Okay, hello. Can you hear me? Just to confirm, yeah, good. Let me share my screen. Oh, you have to stop sharing your screen first. Mansoor, thank you. Okay, so you guys are seeing this? Yeah, perfect. Okay, good morning. Sorry I'm post-night, so sorry if I can't speak English. So I'm happy today to talk about how to become a master of Glidescope intubation, because I think it's an important topic, especially now with all the COVID that we've had and, you know, the quasi exclusive use of Glidescope for intubations lately. So let's discuss on how we can become masters of this. Let me hide this. Good. So today the objective of the presentations is going to be a very short one. It's to identify what are the potential pitfalls of a Glidescope intubation and try to be able to name some of the tips of troubleshooting measures that you can use if you're having trouble with your Glidescope intubation in the near future. If you have questions, just open your mic and let me know, because I basically remove all the rest so I can see. I must admit, I really love Glidescope. It's actually, I will say, I'm in love with Glidescope. And since I've been a resident, I always like to use Glidescope, because not only I can know exactly where I'm going, I find it is a little bit less traumatic than using the traditional laryngoscope. And I don't know, I find it slick and it usually goes pretty well. But there's a dark side to Glidescope. And I'm going to show you right now a video that explains very well what you can encounter when you decide to use Glidescope and you don't have much experience. So although it's such a cool device and we all love it, remember that it's not always that easy to use. So let's have a look at it.
Paralyzed. Okay. Okay, go. And I'm going to slip in here. There's a cord. Pull down a little bit. No.
Got 15 of the accommodate.
Okay.
Okay, another 15 of the accommodate.
Yeah, 98, you're good. A little crack more pressure. There you go. Try and pull her mouth down a little bit, see if you can pull the side corner of her mouth. So.
Okay, so that was a very long video. I don't know if you guys noticed, but this was 1 minute and 10 seconds long, and the intubation was still not successful. So I'd like to give you my first pearl of the talk, which is not a tip, but mostly a pearl. You have to practice. So Glidescope is like any other thing. You really have to practice to become good at it. And then you should start first using it for the routine cases. So those trauma intubation that you think are going to be very easy, the intoxicated drunk person that you think is going to be anticipated an easy airway. And then you go to the difficult airways, the bad mandibular abnormality, the person who has no neck, no chin, and no cervical motion. This is where you want to use it after. And then you become a Glidescope master, because you basically encounter multiple scenarios where you were able to troubleshoot. So don't forget that you need to practice, even though it's one of those devices that are interior is a little bit easier to use. So let's go over the procedure together. So keeping the video in mind, we're going to try to separate or decorticate basically that video and that procedure to try to come up with a certain approach to Glidescope intubation. So there are really 4 steps to a Glidescope intubation. And the first one is to look in the mouth. So to introduce your laryngoscope or your Glidescope blade, look in the mouth first and make sure you're not inserting it blindly, hurting the lips, hurting the teeth, or hitting the tongue with your laryngoscope. Once you're going to have a successful introduction of your scope, look at the screen. You want to try to obtain the best glottic view you can before you go and insert your tube. Step number 3, I think, is the number one. It's actually the one that we always miss. You want to look in the mouth when you introduce your ET tube for multiple reasons. First, again, you don't want to do any trauma by blindly introducing your tube forcefully when you're not really looking at where you're actually introducing it. But also because you want to make sure that you're not rubbing that little balloon at the end of the ET tube against the teeth, because this is where you can actually pierce the balloon. And then once you try to inflate and your tube is in and this was a difficult intubation, you don't want to be replacing it like 5 minutes after. And then at the end, you want to look at your screen again to be able to see if you passed the ET tube successfully between the cords. So 4 critical steps: you look in the mouth, you look at the screen, you look at the mouth again, and then you look at your screen again. So pitfall number 1. The pitfall number 1 is that we're going to have a look at the video. You see the cords, just like in the video. You see the cords very well, actually, but you cannot get the tube into the mouth. And look how he is struggling, or he or she, but I think it's a he, struggling to just try to insert that tube in the mouth. He actually needs some help from another person. The tip here is that your blade might either be inserted too far, but most of the time it's because your blade is taking all the space in the mouth. So if you do a midline insertion, and that's actually how you should, in theory, do the Glidescope intubation. So you take your blade, you go in the midline, you're going to get a fantastic laryngeal view, but you're going to have very limited space to introduce your tube at the corner of the mouth. So my little tip is that do a modified insertion. You can go midline, but then shift it to the left. You're going to have an adequate laryngeal view. Yes, it's not going to be right in the middle of your screen, but you're still going to see the same image. It's just going to be shifted to the side, and you're going to have a lot more space for your ET tube insertion, as you can see on the right of your screen. So shift it to the left is my number 1 tip. Pitfall number 2. Let's have a look at that short video again. So again, you have that great view, right? We see the nice cords, but look at this. Your tube keeps hitting the arytenoids. So you're not able to put it through the cords. And honestly, be honest, guys, that's the most common things we encounter. We see very well, and then you ask that cricoid pressure. And in theory, with the Glidescope, you really shouldn't be needing this cricoid pressure. So you keep hitting the cords or right behind the cords. What can you do here to help? And you can see that in the video, this is where he struggles the most. It takes him about 40 seconds until he's actually able to do something else to troubleshoot it. Tip number 2 is pull your scope back. We're very eager to go and intubate and have that great view of the cords right at the camera level. But then when your scope is too far, you're basically taking all the space for you to be able to maneuver your ET tube. So tip number 2 is back up your scope by 1 to 2 centimeters. That's going to allow you to expand your visual field. So you're going to see a lot better the entrance of your ET tube. Maybe you're not going to have as good as a view of the cords, but that's okay. You still want to have some space to be able to see what you're doing with your tube. It's going to also improve your approach angle because, again, you're creating a little bit more space. So pull back your scope. I'm sure you've heard of the concept of epiglottoscopy. So that's the concept of taking your blade and inserting it in the vallecula and not necessarily putting it under the epiglottis. That will basically help you to push up all the soft tissue of the base of the tongue and the larynx and lift up the epiglottis so you can actually see right below the cords instead of just lifting the whole thing, including the epiglottis. That's the concept that Ron Walls keeps talking about. So here we have the ideal view that you'd like to have with your Glidescope. You can see that it's not that close, right? You're a little bit further away, but that's what you want. Why? Because again, you have a lot more space for you to be able to maneuver the ET tube all the way to the cords. Good? Very good. So my tip number 3. So when you see, I'm just going to go back 2 seconds, that you are struggling like this. So your tube keeps hitting the arytenoids, it's really not working. Even though you've tried your best and you pull back the scope, you're not able to pass the tube through the cord. What can you do? Tip number 3 is make sure your ET tube is shaped like a hockey stick. So you hockey fans, that's perfect. The trick, let's say you don't have the rigid stylet that comes with the Glidescope, because when you have the rigid stylet of the Glidescope, that's perfect, just use this. But when you don't, you can shape the stylet like a hockey stick. So you're going to go with a 90-degree angle, about 8 centimeters from the distal end of the tube. This is really where you do your mark. So let's say you have an RT that's not used to do this. Well, do it yourself. So 90 degree, 8 centimeter from the distal end of the tube. And that's, of course, when you have that malleable stylet, not when you have the rigid Glidescope stylet, which is honestly, I think, the best. Tip number 4, again, thinking about the fact that you're not able to put the tube through the cords, is that try to optimize your maneuverability. I can never say that word. The perfect insertion technique, you have to hold your tube at the proximal end, okay? Not too far below. You really want to hold it there. What is it going to do? It's going to help you being able to rotate the tube, and that is really, if you have to remind one thing about that remember one thing about that presentation, is that this is the key. You want to be able to rotate the tube easily to be able to really put it through the cords. That's it. And the insertion, I hope I have a picture about this. Yes, so we're going to have a look at it here. This is the perfect insertion technique. Look at how he's entering with the ET tube. Very good. So the ET tube, if we go back to the video, I'm just going to go back here. And I'm going to pause it right here. So removing that little plastic thing. And I'm going to stop right here. So see his approach angle. He's basically entering the tube rotated. So the tip is actually aiming to the right cheek or right side of the mouth. He's not entering midline with the tip pointing up. It's really pointing towards the cheek. And that's really, really important. Once you've entered here, we're going to be looking at the screen. I'm not sure in the video if they're going to show the screen. Yes, they are. Look at the approach angle, how different it is. You're going to be coming with a superior approach, and then you're going to be right in the cords. While in the other videos, when you enter midline, you're basically aiming posteriorly to the cords. So the trick here is really to enter with the ET tube in the rotation, and then holding it at the proximal end, you're just going to have to turn like this, like a little bit, and then it's going to really go through the cords easily. Pitfall number 3. You're in. So you are have successfully done all those maneuvers. You've entered with the right approach angle. You've created some space with your Glidescope. You're in the cords, but you're not able to put it through the cords. And that happens all the time. And it is actually normal because that's the whole nature of the Glidescope, but also the rigid stylet. When that happens, you have to stop, pop the stylet, and drop your ET tube. So basically what you do is you're going to say, okay, I'm at the cords or right above the cords. You're going to ask your RT. What I say, please remove the stylet. And as someone is removing the stylet, I am dropping the tube or pushing it down with less of a sharp angle. And it's basically going to go through the cords without any problem. But you really have to remove the stylet as you're pushing the tube through the cord. So the stop, pop, and drop, that's going to permit you to really intubate successfully. Very good. So we're basically done. I want to just try to, usually it's more interactive, but if you can get the tube into the mouth, you have to shift the scope to the left, make some space for you to be able to intubate. If you can get the tube through the cords, there's multiple things that you can do, right? Pull it back. So pull back your scope to create some more space. Make sure you have either the rigid stylet that comes with the Glidescope, or shape your ET tube like a hockey stick. And finally, most important tip, in my opinion, make sure you're able to optimize your maneuverability. So get a proximal grip and also enter on a horizontal axis. So then you can actually twist it after when you're right above the cords. And finally, if you're stuck at the cords, don't remember the stop, pop, and drop technique. That's really going to help you getting a successful, easy peasy intubation. That is a quote. So I remember when I did that presentation, I was actually still in residency. And that was after listening to an EM rap podcast, where Ron was basically saying, advocating that we should always be using the video laryngoscopy for our patient because it's in their best interest. And I kind of agree with him. But I think you still need to be expert in both techniques. And I'll tell you why. When maybe not the Jewish, but sometimes in certain hospital in, let's say, Valleyfield, where I work, you'll be called for code on the floor. You don't have Glidescope on the floors. So when you decide to intubate a patient because there's a crashing airway, or I don't know, they're in cardiac arrest and you're there in your sequence that you need to intubate, there's no Glidescope. So you need to be comfortable intubating with direct laryngoscope. So I think you need to be expert in both techniques. Yet I think it's very important. I think the Glidescope has become very important in our practice, and we can see it with COVID, and you need to practice to become good at it. Are there any questions? And I'm going to stop sharing my screen to see something. Okay. Any questions?
There's one question or one comment here from Dr. Deschamplain. Maybe you can comment on the fact that not all Glidescope are the same. The disposable blade is very different than the non-disposable one. Do you have anything to say about that?
That is a good comment. Honestly, I think in both hospitals that I worked, both of them, I think all of them are disposable. I don't think I've worked with the non-disposable. In South Africa, I think maybe I've worked with it, but I don't really remember. You have to remember that let's say the CMAC is completely different. That's another type of video laryngoscopy that has a different shape of blade. But even the CMAC device might have a very hyper-angulated blade like the Glidescope. So there's multiple various things. I'm not really sure. I didn't really encounter the different types of disposable, non-disposable blade. And maybe François, if you have more experience, you can definitely add on this topic. But do you guys feel like it's exactly, because that's what happens, right? You're always hitting the arytenoids on the posterior aspect of the cords.
I don't know if you guys can hear me.
Yeah.
Yeah, so my comment was we used to have a non-disposable blade that we changed for a disposable one at the MGH during the pandemic. Hopefully we'll get our non-disposable blade back. Very different blades, much thinner than the non-disposable one, and also more angulated. So the regular, well, the regular, I don't know if it's a good word, but the disposable blade will get you by for most of the intubation and most of the, I would say, regular difficult intubation. But for the very difficult intubation, much better view with the thinner and more angulated blades. So ideally, if an emergency would get 2 Glidescope, I would highly suggest that you have one of each. The downside of the non-disposable blade is that usually you lose the blade for cleaning for a few hours when it's sent away from the emergency. So you don't want to overuse that because you probably only have 1 or 2 blades in the department at a single time. But it's a much better tool. Some of our anesthesiologists actually do not want to use the disposable blades because they feel it's a crappy blade. So just my little 2 cents on that.
Thank you very much. Any other questions?
Another quick question, Laurie. It's Will.
Yeah.
Hi. I didn't. Maybe I missed it. Difficulty getting the tube in. Did you mention sometimes rotating it counterclockwise, or because it's hitting the rings of the trachea? And did you say that?
That's a good idea. So once you're in the cords, it's what's his name? Kovacs, the guy from Halifax. He mentions that so sometimes when you don't have the right approach angle, you're a little bit too angulated, and when you're going to enter your, let's say that's the trachea, and you enter your tube a little bit with this angle. And then one of the trick is actually to rotate a bit. And when you're rotating, you're going to have a bit of a better approach for you to drop your tube and really be able to fully insert in the codes. That's a very good point, Will. You know what I'm going to do? This presentation was based on an article published in, I think it's Academic Emerg Med or something, that I'm going to all send to you. But I'm also going to send that little Glidescope blurb of Kovacs on this. And this tip is also mentioned. It's an extra tip, but that's a very good point, Will. That will definitely help you to try to, so that rotation that you have when you're holding it proximal is such a good tip for you to be able to better maneuver. Not only to approach your cords, but when you're in the cord to try to push in the tube. It's a very good comment. Good. So you're going to all master your intubations. Thank you very much for your invitation.
Excellent. Thanks, Laurie. That was super useful. We're going to take a 15-minute break now. So we will see everyone back at 9:45. Okay, guys, welcome back. We're just waiting for Valérie Homier to join us. So as soon as she's on, we'll restart. Okay, so it looks like Dr. Homier is here. So whenever you're ready, just share your screen. You just need to unmute yourself. We don't hear you. Oh, now try.
Is this working?
Yes, it's good. It's working.
Perfect. All right. Okay. Sorry, I had to change earphones and completely tangled. You can see I just on the cord. So let me put this in a complete view so you have a better screen there. You see it well? Can someone confirm?
Yes.
Excellent. Audio is good?
Yes, it's good.
Excellent. We're all set. So let's start. This is Pandemic 101 and the hospital management of COVID-19. So these are the objectives that I wrote down for the talk. So review the core knowledge about pandemics, explain the hospital management of a pandemic, and present some positive elements of the hospital response and where improvement might be needed after the first wave. Okay, so that's what I identified for 3 objectives. Hopefully that works for you. We're going to try to use the chat a few times so that it remains interactive. I see that I left the lights open and it might be causing a little bit of problem there with the view, but from what I see, it's still okay. We'll stay like that. So I have to tell you the last 24 hours, I was kind of focusing more on this in terms of my kind of reviewing, and my mind was with this. Some of you might know I've visited twice Lebanon in the last 2 years, and I've helped set up the first emergency medicine conference in a city called Byblos. And so this is huge, and I know a lot of people who are extremely, extremely busy right now dealing with this mass casualty incident in the middle of a pandemic. Can you imagine? This is insane, insane. So we're not necessarily going to change our topic for the presentation today, but you can only imagine the challenges of managing MCI in a pandemic, not only dealing with the acute casualties, but dealing with the aftermath. No access to the port, homeless people that don't have a home. And so probably we expect higher rates of COVID-19 spread in that country for sure. So we'll have to monitor the literature and learn from that. MCI during a pandemic, this is going to be a huge learning experience for the entire world. Okay, so for those who haven't seen the videos, you must connect and watch those explosions. From friends I know in France, they have exactly the same event that happened to them in a city called Toulouse. And it was an industry that had the exact same compound called ammonium nitrate. And that was what exploded in that same city in Toulouse. But this was 10 times more powerful. We're talking about 3,000 deaths today. So why I'm bringing this up is because things keep happening. So MCI and pandemic is happening now, will happen in the future. And a similar type explosion happened and destroyed a port in the early 20th century in Canada. Does anybody know in which city? This has remained the largest explosion to ever happen before the atomic bomb. Someone answered?
Halifax?
Halifax.
Absolutely. If you visit Halifax, you must go to the Maritime Museum and read about this huge disaster that happened actually in the middle of the winter. So it's absolutely mind-boggling what happened there. Okay, so let's get back to our topic. So basically history repeats itself. That's the initial thing I'd like to say about pandemics. So we can see in the last century all these pandemics that happened, and some elements we're going through, the need to isolate, the fear that we saw, especially at the earlier stages of the pandemic in the population amongst healthcare workers, the crisis management problems, those are not new. And for me, when I'm reading the literature about previous pandemics, I realize how many elements are similar to what happened in the past. So I think this is very important. I will personally take this as I guess a goal for the second part of my career. Well, I'm thinking a 20-year career, maybe it's be more, but I'm at 10-year right now. So I graduated in 2010, it's been 10 years. So, you know, you try to make better each decade. So the next decade, I think that will be a focus, is making sure that what we are learning will serve future generations in a more efficient way. So, okay, so that's the idea. So pandemics have occurred. There's no doubt about that, not only in the last century, but even before. You can see here the timeline for many, many years, centuries in the past. What about Ebola in 2014, 2016? Was it actually officially a pandemic? Does anyone know the answer to that? Was it labeled as a pandemic?
No.
Okay, correct. It's concerned that called an epidemic. And so we'll go over that why very soon. But the answer is correct, no. but it was declared a public health emergency of international concern. That was a designation that is given by the WHO for events with a risk of potential international spread or that require a coordinated international response. So that was certainly the case. So a few things about Ebola that some of you might not quite remember, especially the more junior members of our team here. Well, the index case, the first case, was in a rural area in Guinea. And from there, it spread to the capital, Conakry, and then to Liberia and Sierra Leone, the neighboring countries, and then went to 7 more countries, including other African countries like Mali, Senegal, Nigeria, but also Spain, Italy, the UK, and the US. So a lot of countries. So why wasn't it considered pandemic? So that's still where I'm trying to pinpoint your knowledge there. So definition of a pandemic. So this is the classical definition here, an epidemic, occurring worldwide or over a wide, very wide area. So crossing international boundaries and affecting large numbers of people. Okay, so that's the classical definition of a pandemic. Some people will comment, as epidemiologists, saying that that's not enough. We need to characterize further by talking about transmissibility, which some of you might know to be quantified by the reproduction number. So R, the average number of people infected by a single infectious person. So question for the chat. And sorry, I just somehow did not show my chat. Conversation here. Okay, I was looking for the word chat here. Now I see it. That's good. So did someone answer? Okay, so I have measles. Correct. This is absolutely correct. So remember this, measles is so infective. We have a reproduction number for measles, 12 to 18. Of course, there are many sources and numbers vary. So for COVID-19, between 2 and 6, we see reported, okay, I'm approximating, I've seen 1.4 to 5.7, but roughly 2 to 6. MERS in Saudi Arabia was 0.45 to 3.9. Ebola that we just talked about, 1.5 to 2.5. So by far, measles is the right answer. Okay, so moving along here, another way to characterize a pandemic. Don't forget this talk, this first talk is really to review pandemic 101 knowledge. So I'm just trying to pinpoint the stuff that maybe is most important summarized here. So to characterize a disease and effect involved in a pandemic, you can consider the severity of the disease, which can be estimated by the case fatality rate. So what's the formula for that? Pretty simple, epidemiology again here. So number of deaths on the total number of cases times 100. So for COVID-19 in Canada, there's a reference here down here. So there's a lot of publications on COVID, it's insane. But this one is from CMAJ. So I'm not an epidemiologist. I can't explain you exactly how they adjusted for the reported rate, which could be here less than 50%. They make adjustments to the CFR for that. So they estimate that it's 1.6%. They also think that it's less than 2% in the US. And so basically the message is this is influenced by demographics, the comorbidity composition of your population, how prepared your healthcare system and how available the healthcare system is, how you make diagnosis, how you treat, how you prevent and implement control measures. So this varies between countries and sometimes even between provinces. So that's why you have to realize that the numbers will change a lot. There's so many variables. Okay, so that's good. Moving along, this is another core element of knowledge. The WHO pandemic phases here are listed here. So they correlate with some of the preparedness phases in the emergency management. So we're always trying to do risk analysis, mitigate the risk, prepare. Then when there's an incident, we respond, and then we need to recover. and learn from the event that just occurred. So this is a cycle, and we have a preparedness phase that corresponds to phases 1 and 3 of the WHO pandemic. 4 to 6 is actually the response. Okay, so I'm just going to show you the next slide so it's a little bit more clear, and we can go back after to the other slide. So phase 1, there are no viruses circulating among animals. Phase 2, by the way, this was based on influenza, so often you read influenza everywhere there. So animal influenza virus is known to have caused infection in humans. Phase 3, you have sporadic cases or small clusters of disease in people. Phase 4, you have human-to-human transmission with community-level outbreaks. This is important. And phase 5, human-to-human spread of the virus into at least 2 countries in 1 WHO region. So coming back to our case of Ebola, okay, so look at the regions here. You can see, take a look. Those are WHO regions. So they say you need to have spread at least 2 countries in 1 WHO region. So we had that for Ebola in 2014. So again, why wasn't it a pandemic? We'll go to phase 6, which is the actual confirmed pandemic, the global pandemic. So that requires community level outbreaks in at least 1 other country in a different WHO region, plus all the phase 5 criteria. Okay, so I think that's where the issue was with Ebola, is that they did not confirm community level transmission outside the, I guess the, how do you call it, Africa region. Okay, so I guess that's the reason. So that's it. And then after the post-peak period, the phase 6, you have the post-peak period. So you have disease levels that have dropped below peak observed levels, and then post-pandemic period, now we're back to normal levels of disease, so no outbreak. Okay, so that's kind of really important, and that's how WHO makes determinations. Now, some could argue that sometimes the declaration, it comes late or doesn't come or things like that, but I mean, this is the core knowledge we're trying to review. Are pandemics caused only by influenza? That's one other question I had for you. Where's the chat? No, okay, perfect. That's correct. It sounds like unanimous. Absolutely, you are right. So I just bring something to your mind that none of us really had to treat, and unless you went to do assistance potentially in Haiti for the earthquake, or if you went to another humanitarian assistance project or sort of mission. That's the word I was looking for. So there were 7 cholera pandemics throughout the history. And basically the first one originated in India, and this was back in 1817, right? So basically cholera, what is it caused by? What leads to that? So improper human feces and improper management of human feces and no treatment of drinking water. Those are the 2 things that lead to cholera pandemics, right? So basically, it's not eradicated. Does anybody know where was the last outbreak? There's been outbreaks after these pandemics. Where's the chat? Maybe some of our Middle Eastern residents would know this. Yeah, that's it. Fad, way to go. Yemen, 2016. That's correct. So that's not that long ago. Anybody knows how we treat cholera? Yeah, supportive care, IV fluids, sure. What else? Oral rehydration, antibiotics. Yeah, what kind of antibiotics? One category. Tetracycline, exactly. So doxycycline, absolutely. Good. Okay. All right. So good. Hopefully we don't have to deal with that, but certainly it's still existing. All right. So the COVID-19 pandemic, the stats as of August 4. So in turquoise worldwide and in red for Canada. So 18 million worldwide, Canada 117,000, or about 59,000 in Quebec. Okay, the deaths you can see here, there are 188 countries reporting cases at this time. Okay, so this is where we're at. What we're gonna do now for this next part of the presentation is to go back in time a little bit and try to teach you a little bit how it all started in terms of hospital management. And I know there's other people here that are working from other institutions, and it would be nice to see if they had the same experience at the beginning. Okay, so March 12, 2020, we had 13 confirmed cases in the province of Quebec, and that's when we had the start of confinement measures in Quebec. Okay, so basically this came with mandatory confinement for all healthcare workers returning from travel or with flu-like symptoms. This was also mandatory for like daycare personnel, public health servants, and also teachers. So education was all mandatory confinement. Other people returning from travel was a voluntary confinement on March 12th. It was recommended or obliged, I guess, to cancel all non-essential indoor meetings of 200 people or more. So conferences could not happen, things like that. Okay, so that's how it started. And so for us at the MUHC, I will say MGH and RVH. Well, what that meant is we had our director of MUHC ED who was stuck at home, could not come to work because returning from travel. Same thing for my colleague and medical co-director of emergency measures at the MUHC, Dr. Khalil, same thing, stuck at home. And also the director of professional services, Dr. Sidorovitz, stuck at home because of travel. Of course, this was right in the middle or right after March break. Okay, so for us in Quebec, that was a big deal, as you know. So these key people that I just mentioned could not come in person. So that was huge. That was huge. And in the beginning, we did not have Zoom. We did not have any of this. So I would say that the most important step at that time that was taken, it sounds stupid, but it was to determine the emergency department command center and for the institution to determine the hospital incident command center to launch it. This is what they call in French the CCMU, Centre de Coordination des Mesures d'Urgence. You've been hearing CCMU all the time, but that's what it is. It's basically a hospital command center. So that was a key decision. So for us in the emergency department, we used the medium conference room. We basically just booked it, and this was the pandemic, emergency department pandemic office, we called it like that. And so that became a very important room. So for me, this room forever is associated with the pandemic. You have no idea how many hours I spent in there. It's just hard to even think about. Actually, it was kind of hard preparing this presentation. It was just like reliving the whole thing. But yeah, so that's where it was. And for the hospital command center, maybe you don't know that, but initially it was, as per the plan, supposed to be in the basement at the Glen in the S2 level. So you probably never been there. So it's a large room, and that's where we hold our emergency measures meeting. But in the end, they had to move because it was too small. They couldn't fit everybody they needed in there. Okay, so very important step. I'm going to talk a little bit about here now what is exactly a hospital command center. But first, I just want to mention that when all this happened, March 12th, the confinement, it's not like we knew nothing about the pandemic. We were in the preparation phase. We had conducted already a simulation in February. And you see at the time, we had different gowns for different types of procedures. So if your patient was in cardiac arrest, which what happened to this patient, they had to wear the blue gown. And even back then, I remember, it was so hard to find equipment to run the simulation. They were already watching the stocks. So these gowns there, they were very precious. And I could never have organized a large scale simulation, even at the end of February, but with all this equipment for everybody. It was a huge problem. Okay, so yeah, this is February 25 and the multidisciplinary sim. You may not know this, but it was conducted on every site of the MUHC. And It was involving emergency department. Everybody was invited. Radiology, we invited also ICU, infectious disease, emergency measures, nursing was involved. These are PABs that you see there. And so, you know, we learned a lot from the simulation. But so we were at the preparation phase and we knew everything that we had to work on. So stockpiles of PPE, donning and doffing was a huge problem. Nobody could do it properly. Nobody knew exactly the steps, what they're supposed to do. And also what to do with the space. That was the big issue. Like we had no space to put patients. Do you, anybody know, and I'm gonna reactivate the chat here, I don't want you to get bored, but do you know where this is? Like, do you recognize? I'll give you a hint, it's at the RVH. Do you know what room this is? Anybody? No? Just say something on the chat so I know that it's working. Ah, okay, toilette. Actually, that's the decon room. So I'm showing you this picture not for fun, okay? But it's for you to realize how hard it is to prepare when the emergency department is overcrowded. So we had planned to run the sim in recess room 53, which is normally our respiratory isolation, one of our respiratory isolation rooms. But the problem is the department was full and they needed the rooms to actually properly isolate patients. So we actually couldn't do it there. So we decided to use the decon room, which nobody goes to, and we don't really do decon there. We only like shower, no fixed address patients or whoever needs a shower, like in terms of patients, that's what we use it for mainly. Okay, maybe for decon of a small, very like one person for chemical contaminant, for example, but it's not used for patient care. So we said, okay, we'll use this as our room where we can run a simulation. So, you know, you have to be creative and find space where you didn't think you had space. And that was a good decision because we were able to really practice, even if it's not exactly the same room, it's still in the same department with the right people on shift, you know. So this was not announced like exactly what they would be, but we had sent a message to the workers that we would be conducting simulations on all sites. So we even tested the clinics, the walk-in clinics, to ensure that they knew how to screen patients. Because at the beginning, like, we didn't know and there was no screening happening. So walk-in clinics were tested. MGH, RVH, MCH were tested. So that's where we were at. And now we were gonna deal with PPE problems. We were gonna try to structure ourselves, a leadership structure, like this was all gonna happen. But then it was kind of right there. Okay, so March 14, declaration of state of emergency in the province of Quebec. So that's it. So I told you about the office, securing the offices and starting the hospital command center. I'm going to show you this slide here. So this is the composition of the hospital incident command center that was launched at the MUHC. So this is a slide that I got from Louise-Julie Brassard, who is our emergency measures coordinator. So this is obligatory in this province to have one per hospital, and they are the direct link with public safety, which normally is the entity that is managing disasters. Okay, now this was challenging because this is a very medical disaster, and emergency measures coordinator are not necessarily medically trained, and so they had to collaborate a lot with the Ministry of Health and directives coming from public health. So there was a lot of confusion as who's supposed to send what direction or guidelines. And but she did a fantastic job at launching the CCMU and making sure that telecommunication and phone calls and conferences were happening with governmental authorities. Okay, so they, as a CCMU, were in contact with governmental authorities, and this is the entity that made decision in the pandemic. So PDG means Président Directeur Général, so basically CEO, Assistant CEO. Then you have Director of Nursing, Director of Human Resources. You have Director of Professional Services, Bed Management, you have OptiLab, which is the director for managing all the labs. That's a big, big deal when you need to optimize your testing capacity. Infection control, so we had Dr. Frenette and Dr. Rajda. That were two adult infectious disease specialists. There was one from the children, for some reason I can't say her name. It will come back to me, I know her. You must know her as well. And also one infection control nurse that were present at these CCMU meetings, which were held twice a day, morning and afternoon, okay, in the hot period of the pandemic. There's also communications director, the emergency measures coordinator. And also DST is service technique, so director of technical services. Does anybody know in the residence why the director of services is so important? Let's apply it to the pandemic, my question. What is happening under this person's leadership? And a hint is the N area at the MGH. Okay. Yeah, refitting the rooms, exactly. So the N area is, for me, a fantastic example of reinventing ourselves to adjust to the challenge, the disease. And so the N area used to be a psychiatric unit. So there were no bed monitors, there were no HEPA filters, no negative pressure room capabilities, nothing like that. So these people worked so hard, and they had to be led by a director and conduct all these changes, modifications to the structure of the rooms, to the equipment in there, to organizing dialysis where there was no dialysis, and organizing also the negative pressure rooms, make sure that we could get more, because we had 2 at the general. That's insufficient, absolutely insufficient. Okay, so now we're moving along to show you a little bit. Now we'll get to a little bit where my role was. I was not a member of the CCMU. I did not sit in this office, I should say. It's a large room, a conference room. They have somebody there, secretary managing. There's documentation of every meeting, and there's tasks, action sheet for everyone. So this is very structured, and everything is documented. Okay. So there are subcommittees that are functioning under the CCMU to really accomplish the work more on the ground, but they are keeping the control, the leadership structure, so it's really connected. So basically there was a group that was working on organizing simulations. This was under the director of education. There was a PPE task force responsible for finding PPE and ensuring stocks were properly maintained. There was also a committee looking at what are the new types of PPE we could use, like thinking outside the box. There was also, later on, this happened later, a committee where we were reestablishing services, which means we had stopped, like canceled elective surgeries, canceled the clinics, all of that was stopped, and you needed a committee to progressively launch them back. My role was in the surge capacity committee. So I don't know if it should be called a committee. There's very few people on that committee. There's myself, and there was an administrator, Mr. Charles Hubert de Lille. So he's an administrator in the hospital, high-level administrator, who basically was assigned to this task with me. And also Jean-Marc Roquet did participate in some of this as well as director of emergency department. Okay, so I don't know if you see this super well because maybe the quality of the picture is not great, but this is the document that we were generating every day or every other day at the beginning. And so we have started working on this way before being asked to do something like that by the government, by the ministry. So basically it's for all sites to figure out where to put the patients. So filtering, that was imposed by the government, the hospital. They hired security people to filter and determine who had symptoms and should not be working, and also to avoid that all unnecessary visits come to the hospital, like no visitors. So that's non-medical step. So my job was dealing with steps 2, 3, 4, 5, 6, and 7. So figuring out where do we do the screening, you know, for people who don't need hospitalization but need screening for COVID. Those who actually need the symptoms evaluation but are likely to need to come in, or if they don't need to be hospitalized, they at least need to get further testing, maybe for another differential other than COVID that can't go home right away. And then you have all the columns for admission. So you have the non-COVID admission, which is the last COVID, column, and then 4, 5, 6 is suspected COVID-19, non-ICU, confirmed COVID-19 non-ICU, and then both for the ICU admission level. So this document was updated very often and required visits to each site to figure out where can we do all of this and where are we putting these types of patients, these different categories. So this was not pre-existent, and definitely harder to do in the older hospitals where there are much less single rooms. Huge challenge at Lachine, huge challenge. I'm going to say that again. For me, this was my biggest worry since the beginning, because they didn't have the space, did not have the space. And I encourage everybody in this residency program to make sure they see Lachine Emergency Department before the end of their residency. You need to go over there and see it. I have to say, I graduated without seeing it. I've not been to Lachine my entire residency. There were no rotations there that I recall. I never happened to go there. And I realized it was a missed opportunity because they have their own challenges. And we need to be taking the opportunity to learn what it's like to work in a small community-like hospital, which, yes, it's with the MUHC, but not really. They don't have the same number of people working there. They don't have the same bed capacity. They don't have the same level of consultant support, especially off hours. And the space is old and very tight. So for those reasons, they have their own challenges there. And in addition, they are located in a low economic level community area where they have a lot of COPD patients. And inside the building where the hospital is, there is a special CHSLD for ventilated patients. So they were really worried that all these people would get infected. So they had to seal off that area. They had to do a lot of adjustments. And I do need to point out the importance of identifying local heroes in the process of managing the pandemic. And for me at Lachine, it's Dr. Nicole Ezer, who did an absolutely outstanding job as designated DPS during the pandemic. She really went out of her way to protect the staff and the people. And some of you might have seen the tents. There are officially 3 tents at Lachine at the moment. One for screening, one for a resuscitation tent, and also, which is different, we don't have that elsewhere at the MUHC, but there is a unit, a ward, like you can do sort of management of suspect cases in the tent, not just screening. It's actually a really nice a tent there for that. Of note, we have launched a project to document all of this work, this surge capacity plan. All these areas have been filmed, most of them actually, and it's in the process of being editing. So I think it's going to be a very interesting opportunity for learning, like I said, for future generations, because everything has been filmed. We just have to do the editing, select what we want. And there's a lot of interviews that were conducted with those who were involved in launching these areas, because it's very nice. I go there, I discuss with infection control, with nursing directors, with the doctors at each site. We agree on where we're going to put the patient. We put it on the search plan, but then you still have to get it done. Put the equipment there, connect the Wi-Fi. You need to get the negative pressure rooms. You need to construct, hopefully, some walls protecting different patient beds that are usually just with curtains, for example. So there's a lot of changes need to be done. So the actual getting the job done is much harder than writing this plan. So this is a multi-disciplinary work. So I would say, if we summarize so far, most important initial steps: get an office where you can work and meet with the initial leaders. Number 2, launch a command center like the structure. Okay, so emergency department or whatever department you're in, and hospital as well. And I would say number 3, identify your local champions. For each task that we named here, the subcommittees that are associated with the pandemic you need to build to respond to, and with the challenges you're facing, you need to find the right people to do this. And at the beginning, I didn't understand, to be honest, like I'm being very honest with you. I thought I would be on the CCMU. I'm a medical co-director of emergency measures. Okay, I thought I should sit here and contribute to decision-making. But someone up there, probably rightly so, identified that maybe my best talent is to be on site and actually talk to people and get things done. And just walk on each side, go and check things out. And in the end, to be honest, I think I'm happier having done that than having sat in an office more than I already did. At least I got to move out a little bit. But I have to tell you one thing: leaders in times of crisis will want to lead. And now I'm okay with it. But initially I was like having a hard time with that. I thought I should have a higher level role in decision making, but I'm not a director per se of the official sort of hierarchy in the algorithm. Okay. My role as a emergency measures director is under director of technical services officially. Okay. So you have to understand there is a structure, and that structure is hard to collapse completely. So the CEO decided the directors would manage as they normally do. And we have to go with that decision. It's just important to communicate it clearly so that people understand what's going on. Okay, so so that's a little bit how it worked.
Sorry, Val, just to interrupt. You have.
Wow, sorry, that was so loud. Sorry.
you've got 5 minutes left.
Okay, perfect. So 5 minutes left. Then that's time to discuss the failures. Let's be honest. We should talk about that. And these failures will help us identify what we can do better for next wave. Okay, perfect. So you understand a little bit about what I did. Basically, the surge capacity plan, biggest challenge with that. And I'll conclude. Yeah, so what I'm doing now is concluding on some positive aspects and negative aspects. So positive aspects. So basically, we had a clear decision-making structure in our institution. That's a positive. Second positive element, local champions. I said one, Nicole Ezer. I should say many more that were involved in several aspects. So the resuscitant at the General, that was a huge team, including Dr. Kwaja as leader. FDC helped out. There were all the people from technical services. So local champions, find the right people and give them the proper role with their talents. Other success, the collaboration, and this needs to be said, the collaboration with the children's. You don't see it on this picture because it's hard to read, but we had non-COVID ICU admissions that were transferred to the children's. They took like sickle cell patient, they took Crohn's or stuff like that were relatively stable, but they took them. Same thing, we had agreements that they would eventually take COVID patient, adult patients that were stable, and they would take step-down patients from the ICU. So this agreement was negotiated on the phone, teleconference. It took time, but you had to have all these agreements made. So that's a plus, the collaboration that has never been done before with the children's for admissions. Okay, and then finally, I'll take a little bit more time now to discuss some failures. So one of the biggest failures I've identified relatively early on is that in these committees, as you can see, there is no official committee or person that was assigned to monitoring the literature for the institution. In terms of the new info coming out on Twitter, you know, early on, we didn't know about the thrombotic risk. And for me, that's where I realized that's a problem. I started seeing like internal medicine ordering D-dimers, and I saw stuff on the literature and like the risk of VTE. And so there was no protocol in place. And so the problem was because there was not a person assigned to literature watch and to actually monitor the creation of protocols, but also the updates. Because with new literature, you need to update your protocols, and there should be somebody assigned to do that. So that was something that I think could have been done better, for sure. So the other thing is obtain feedback from your team, because it's a new situation, very stressful. A lot of people took place in, a lot of change were imposed on people, and it's important to get feedback. So we did a QI project, which results will come out soon, but clearly there's a lot to learn from that, and from getting feedback. A QI project is ideal after phase 1 or towards the end of phase 1 to collect what are the problems. And clearly one thing I can say that came out from that QI project was distributed to all workers in the hospital. Either you were working in the kitchen, or you're a doctor in the ICU, or you're a director of nursing, all of you got the survey request. I actually don't know if the residents got I was wanted to ask you that. Just put on the chat, if you don't mind, if the residents got that survey. I'm not sure they did. But all the other hospital personnel got it. And basically, major issues were PPE, of course, concerned about PPE shortages, and communication, which is no new finding. Communication, why? Because, you know, there were emails, there was the Slack, there was the, that's for those at the Jewish, and that Lakeshore, they use that, St. Mary's, but us, we had work jam, so there was that channel to monitor. There was webinars from the FMSU. You remember this whole amount of information, and this is an area we need to improve. Clearly, there's too much email coming and too much difficulty to deal with that. It's not possible to do this like that. We need to find a better way. And also protocols. Initially, protocols were not centralized in one area. Finally, they put everything on the intranet. So that was a good decision. Okay, so areas of improvement. Management of PPE, becoming a little bit more green. Like some hospitals have gowns that can be cleaned, but a lot of hospitals like ours at the MUHC, we just throw everything away because we don't have a laundry facility. I think we should look at the impact of our waste production. You could see on my Twitter, I posted something about that. And then finally, I'm just gonna end here. We need to improve collaboration between sites. I had the opportunity, thanks to Dr. Afilalo and Dr. Sevaraman Suj, that let me go and visit our other sites, St. Mary's, the Lakeshore, and the Jewish, and we find several issues that were a little bit different. So for phase 2, we need to collaborate, and there's a report being prepared of what are some differences that were found, and that will be submitted to them, and they can see how we can adjust better. But collaboration between hospitals, between provinces, between countries has to be improved. We need to share information to improve our response. So I don't know if we have time. Maybe somebody can put some questions on the chat. If we don't have time to answer now, I guess I can respond directly to the people by email. I feel like I have to cut down on the time, correct?
Yes, thank you, Val. So yeah, if people have questions, perhaps they can put them in the chat, and then she can respond. And in the meantime, if Ollie is here, he can start getting his presentation ready. So Val, if you can take off your screen sharing. Ollie, when you're ready, just share your screen.
Right. I'm not sure if you guys can see me.
Yes, we can, and we can hear you.
Fantastic. So hi everyone. Pretty glad to be back in a sense. I've been wanting to do this for a while, and I really managed to get my schedule in order last year. Plus, you know, pandemic, getting a kid, ICU, great combination. In any case, this presentation should be a easy review, and then hopefully for the rest of the year, I'll have some more in-depth and more critical care stuff to present. Very happy about the title. I'll just tap myself on the back for that one. So for the people that don't know me, I'm a 5-year grad from last year, and I decided to do a 2-year fellowship in ICU at University of Montreal. So I've been living in Franglish for the past year, and if I make some weird grammatical errors, my apologies. So I have no conflicts to declare. Objectives basically is to recognize critical from non-critical hypertension. I'm using terminology that's maybe a little bit different from the textbooks, and I'll explain why. Understand the different contributors of blood pressure, list the different treatment options, and to begin and titrate adequate management for patients with critical hypertension and various causes. So far, so good. So we are going to talk about physiology, non-critical hypertension, critical hypertension, a little foray into pharmacology, and then end with management and take home, which is quite convenient because most of you are already home. I already prepared that joke. Thank you. Just to talk directly about why I'm using non-critical hypertension and critical hypertension as opposed to the classic definitions, is that I don't feel that they rightfully represent the reality of Emerg or critical care. When I see a patient in front of me that has organ injuries that's associated with hypertension, honestly, I don't necessarily care that much if he falls into the primary hypertension or the secondary hypertension category. So I just want to know, do I have to do something about it, or is this something that could be dealt in an outpatient basis? So the classic definitions that you'll find in the textbooks, there's primary hypertension, which is basically kind of like the old school term essential hypertension, basically the hypertension that most people are walking around the street with. Secondary is basically caused by a pathological condition, whether it's renal artery stenosis or the good old zebra pheochromocytoma. Hypertensive urgency is an outdated term, do not use, and I'm not even going to describe it because it's being thrown out the window as it should. And then hypertensive emergency, which is kind of the same thing as what I would describe as critical hypertension. It's basically when you have, in a simplified way, an acute organ injury. I don't care if the patient has CKD, right, from his hypertension from years of high blood pressure. It has to be an acute organ injury and associated with hypertension. It doesn't matter if the hypertension caused it, like hypertensive encephalopathy, flash pulmonary edema, or hypertension is a result of an initial process like a stroke. What I'm trying to simplify this concept to is that there is an organ that is suffering and the hypertension is associated with it, and we need to deal with it. It's causing harm. So let's move forward to physiology. I'm in ICU. I have to add an equation because that's what we do. We just make a lot of things boring. Why do we care so much about blood pressure as a whole? Never mind hypertension. But why do we care so much about blood pressure? So, I mean, a minimalistic view of ICU medicine, emergency medicine is just making sure that oxygen reaches mitochondria at some point. But there's no real easy way to measure that so far. So we use an array of imperfect clinical information, vitals, physical exam, ultrasound, labs, as a proxy for mitochondrial well-being. Blood pressure is one of them. And we know that extremes of blood pressure, low blood pressure, high blood pressure, are bad, right? Too little oxygen doesn't get transported, or too much and the pressure starts overtaking the heart, damaging the vascular network, and just causing havoc on your organs. Now, the reason why I'm putting up a boring equation is just to help you think about the components of blood pressure and help us think, well, where's the problem and what are the targets that we can go after? So basically, your MAP, or your mean arterial pressure, is a function of cardiac output and your systemic vascular resistance. And then we all know the cardiac output is your heart rate times your stroke volume. And then your stroke volume is basically a function of these four items. Obviously, rhythm is not going to play that much role in a hypertensive crisis, but the other three are going to be quite important. And so when you realize that blood pressure is basically a component of all these things, then it gives you an idea of, well, what are the targets to go after? Now, I realize that, you know, not all of these pharmaceutical aids are going to be useful in a critical setting. So really what we're left with, because, you know, I'm not going to use DIG to lower blood pressure. I'm not going to use cholinergics to lower blood pressure. What we're left with is mostly beta blockers, calcium channel blockers, and nitric oxide dose. I mean, there are others, obviously, but this is really our tool basket. Not to forget that acutely, a big component of elevated blood pressures has to do with pain, has to do with anxiety, and then there are some other medications that will obviously have a huge impact on the blood pressure itself when we're intubating patients, for example. So just to keep that in mind. So hopefully the physiology part wasn't too painful, and we'll just move towards non-critical hypertension. So non-critical hypertension is basically, just to give you you know, more of a scenario, is basically the person that's coming in from the clinic, from a pharmacy, or even from home because they have a BP machine at home, and they're coming in because of a high number and a high number only. That's it. Hey doc, my blood pressure is through the roof, do something about it. So again, to simplify, these patients with asymptomatic hypertension, no matter what the number is, that evaluation, that treatment shouldn't be done in the emergency department. And the reason is, it's very unlikely for a blood pressure to rocket skywards in a matter of a couple of hours and the patient to remain completely asymptomatic, right? If that blood pressure rise, dramatic blood pressure rise, is acute, usually it's because there's a critical underlying cause or a huge amount of pain, anxiety, or maybe even the measurement's wrong. But otherwise, hypertension is a chronic process. It doesn't just appear from one day to the next. So asymptomatic really is the key here. And by symptomatic, we mean that there's no acute organ damage. And that's what the AHA guidelines, and that's what Rosen says. So more recent 2017 AHA guidelines basically centers around the same point, is that you know, if you have a patient coming in with a very elevated high blood pressure, here they use a number, but numbers aren't as important. It's hypertension plus or minus organ damage. If you don't, then the patient, there's still something that you can do for the patient, but it's not going to be in the Emerg. So you'll notice the guidelines mention numbers, but I don't. Patients with chronic hypertension have very high numbers and no organ damage because they've adjusted their autoregulation. They can tolerate these numbers. On the other hand, patients who are normotensive or even have low blood pressure at baseline, let's say, I don't know, pregnant patients, can have organ damage at numbers that would seem very unimpressive. So that's why I don't think the numbers matter as much as understanding the patient in front of you, right? Also to note, acuity is important. What I was saying about the rise, right? If you increase your blood pressure by 200 in the space of a few minutes, and you're otherwise a normal patient with with a normal blood pressure at baseline, then yeah, that acuity is very important. But if you're a chronic hypertensive patient that's been living with blood pressures at 180 for the past couple of months, if not years, then your body has had time to accommodate, and it's really not going to cause that much damage short term. We all understand that hypertension long term is a problem, but that's not the focus of this presentation. Little note also is that they don't mention MAP, which is maybe one of the numbers that translates most to the damage that is perceived by organs. Obviously, specific situations are different. I think everyone here is thinking of dissection, but as far as organs are concerned, for encephalopathy, for example, the MAP is maybe the thing that is more representative and maybe the target to go after. So acute organ damage, what are we talking about? So we're talking about brain, we're talking about heart, we're talking about vessels, kidneys, microvasculature, and others. Things like epistaxis, a mild headache, or non-specific symptoms that the patient might come with are very unlikely related to their high blood pressure. And it's not what I would call as a symptomatic cause of their hypertension, and therefore they would fall into the hypertensive emergency category. No, so the patient comes in with a high number and a mild headache. Obviously, do your due diligence and make sure there's nothing dangerous, but otherwise, they're still in like a non-critical hypertensive type of category. So far, so good. So I'm saying a lot of things that, we don't need to do this, we don't need to do this, but what can we do for them, right? So again, looking at a blown up view of the guidelines, there's nothing that says admit, and nothing that says investigate, and that's true. No guidelines recommend routine testing in the ER. There's actually a study in the American Journal of Emergency Medicine in 2010 that looked at patients exactly in this situation with hypertension, no acute organ damage. Do we do routine testing or not? So the routine testing identified abnormalities in about 6% of those patients, and none of these abnormalities were directly linked to hypertension. So there's no point really. So no testing. Okay, so what are we actually going to do for them then? It depends. So it's, to me, I'll kind of split them up into patients that are known hypertensives and then a new diagnosis, patient that didn't know they had hypertension and come in with a blood pressure in the 180s. So my take is, like I said, no investigations. For the patients that are known hypertensive that weren't taking their meds or something like that, then you restart them or you re-prescribe them. You make sure that the patient has follow-up, and that's absolutely key. And educate the patient, maybe educate the pharmacist that sent them over, maybe educate the primary MD. So those would be the four things that I would focus on to do for these patients. Now, the guidelines do mention that we should consider prescribing a first or a new antihypertensive for these patients. I have my own qualms with that, and I know that some MDs are very comfortable with doing that and have a lot of experience doing that, and kudos to them. I'm just not a fan of starting meds in the ED, because usually the ED is a situation that is not really representative of their baseline at home. Maybe they're under stress, pain, white coat syndrome. Maybe there's some new meds in the background like steroids or NSAIDs that can increase their blood pressure. Maybe you decide that you want to start some meds like an ACE, an ARB, calcium channel blockers, beta blockers, thiazides, but maybe the primary MD has a different choice than you do, and they're the ones that are going to follow them. And also importantly, there's no harm in not treating those patients. There was a study in JAMA 2016 of 58,000 patients and divided them into treatment and no treatment, and there is no outcome difference at 6 months. So you can, I mean, if it really satisfies the patient, there's nothing that's holding you to absolutely prescribe new antihypertensives for patients with coming with hypertension but that are asymptomatic. So that's my take on that. Now, critical hypertension. So again, to simplify, these are patients with acute organ damage and hypertension. They're patients that are actively being harmed by their elevated blood pressure and need an immediate blood pressure reduction. So, well, what are we aiming for then? Do we reduce by 20 of systolic? Do we reduce by 15 of diastolic? Do we reduce by a percentage of MAP? So what do we do? It's divided into really a general management and specific management. So specific conditions that will require very specific targets, and most other situations that you would kind of call more like the more classic, primary hypertensive encephalopathy or primary hypertensive emergency, that kind of respond to all the same treatment, maybe not the same meds, but the same targets. So if we're talking about targets, then what's allowing us to aim? How are we aiming, right? So there's our automatic trusty BP cuffs. How they work is basically they measure a MAP, and then only after there's an algorithm that calculates the systolic and diastolic. So really the most precise measurement from these BP cuffs is really the MAP. Also, I was always under the understanding that, not having the correct cuff size is going to cause some dramatic error. And there's actually this nifty paper, oldie but a goodie, in 1991, that looked at the effect of a cuff size 1 too large or a cuff size 1 too small. And basically the differences are really minimal, like 5 millimeters of mercury for systolic and diastolic. So not the end of the world. As far as manual blood pressure, it's actually not as accurate as automatic BP cuffs. So if you're not happy with the blood pressure that your cuff gave you, manual is not going to get you a better answer. So honestly, stick to BP cuffs. And then in certain centers, we can go straight to art lines. It's not as easy as just like, oh, okay, we'll just do art lines and that's it, right? You need the entire department to be on board, your nurses, your staff, and the people that are going to receive them also have to be on board a little bit. The advantage is that obviously it's real-time BP measurement, particularly useful in cardiac arrest, for example, or if I'm going to intubate someone with an intracerebral hemorrhage, I'd like to know what my intubation is going to do to that patient's blood pressure, because it's pretty key. Sorry, I'm looking at chats and I'm not seeing the chat, so maybe I should turn on the chat and see what happens. Who's trying to talk to me? Ah, yes. Sorry, a bunch of comments, which I'll get to a little bit later. Sorry, Monica. Where is that? Yes, art lines. So it has its uses, but you need to be able to troubleshoot it. Is your art line damped? Is your art line resonating, or is it giving you a right measurement? Although map is usually going to be accurate. And a lot of people saying that it never really saved anyone, and there's no prospective studies that show that art lines are beneficial. And I agree with that. So it's really it's a tool that's not necessarily, not completely necessary for all conditions. And especially you'll see later that the targets the guidelines mention are not that, they're not that evidence-based. A lot of these targets are basically expert opinions. So why, it's kind of like a circular argument. Is why try to get an absolutely precise measurement when the targets that are asked are kind of fuzzy, right? We all understand that these blood pressures need to be decreased, but the actual numbers and the precision of it is not that clear. So why do an art line when you don't really need that precise of a measurement in the first place? I'm being the advocate, like a devil's advocate. I'm ICU and Emerg. I like art lines, but it's not for everybody. So, and then how are we treating? Which forays into pharmacology? So pharmacology is basically the slide that I had before that was a little bit busy, and that I will hopefully simplify by a wonderful table. I'm just going to name a few agents that are going to be the bread and butter of hypertensive management, and then I guess let us know in the comments if whether you have these agents in your institutions and what you like using. So as far as calcium channel blockers, so if you remember your 3 different classes of calcium channel blockers, the dihydropyridines are really the workhorse for blood pressure management, because they're really going to be more arterial vasodilators as opposed to the other 2 classes, which have maybe more of a heart targeting. So nicardipine is particularly used in neuro patients. I know that we use it a lot at the SHIM. Fairly quick onset. Duration is kind of borderline. So as far as a titrating agent, it's not perfect, right? Because you'll understand that a clinical situation can change quite a bit in 1 to 2 hours, and so the dose that is being given in perfusion might need to be changed, but because the duration is 2 hours, it might accumulate a little bit. Not as much as obviously as agents that last 6 hours, but still. So it's a quasi titratable agent. Liver metabolism, so avoiding cirrhosis, and particularly used in neuro patients. Clofidipine is basically a shorter acting nicardipine, and it's fantastic. I don't know. I know that it's not really widely available. The only place on the French side that uses it is the SHIM. I'm not sure Sacré-Cœur has it. And even then, it's you need to have a good reason to use it because it's quite expensive. Theoretically, not to be used with patients with egg and soy allergy, but this is only in vitro data. So that's our calcium channel blockers. Nicardipine is kind of quasi titratable. Clofidipine is really titratable and quite a useful agent. The beta blockers, esmolol, which I particularly like, esmolol, which is mostly a beta 1. So it decreases your blood pressure by decreasing your cardiac output, right? So to maybe not the greatest for neuro patients, right? But otherwise for certain cardiac presentations like dissection, fantastic. Labetalol, obviously the duration is quote unquote problematic. It's hard to titrate down, but I do appreciate it because it's so easily available. It's one of the quickest things that you can actually get from your nurses, and it's absolutely great as a bolus agent. Because fine, it's hard to titrate down, but you can still titrate up, right? And so that's exactly how it's meant to be used. You give a bolus of 10, you see the impact fairly quickly. Are you happy or are you not happy? If you're not, then you double your dose. You go to 20. Are you happy or you're not? You go to 40, up to 300 in a day, I believe. So quite useful before you can get other things on board. As far as the nitric oxide donors, nitroglycerin really is the workhorse of that category. A truly titratable agent, very useful. Obviously, to be careful in RV failures, in people on Cialis, Viagra. It can cause some reflex tachycardia, so it's quite lovely to use with beta blockers. And then the theoretical, I wouldn't say contraindication, but is that it causes great systemic vasodilation, but more so than in the cerebral circulation. And so what happens is that there is a kind of a little bit of a neurological hypoperfusion. So less of a great agent again in neuro. Its other cousin, nitroprusside, which is truly titratable, but still, even though like the onset and duration are quite short, it's still difficult to titrate. It still has some white swings sometimes. And then it comes with the issues of creating some lactic acidosis, which is problem in critical care patients when you don't know where what your lactic acidosis is from. The cyanide toxicity, obviously, but it's really if you use it at like a pretty high dose and for multiple hours. I mean, not to be ignored, but you know, a lot of people make a big deal out of it. There is such a thing as coronary steal from it. So some of the healthy coronaries will dilate more than the non-healthy coronaries, and therefore the ischemic parts of the heart will get even less perfused, so not great in MI patients or CAD patients. And then some reflex tachycardia, which obviously happens a lot in vasodilators. So maybe not that great. I think nitroglycerin is a perfectly good agent, and some might argue that it's more of a venodilator, but at a high enough dose, and people very often underdose their nitroglycerin. They're too afraid to go high. At a high enough dose, and I forget exactly which one it is, maybe Sophie will be able to help it. It becomes an arterial dilator, so no problem with that. And then others that are used sometimes, enalapril, I've never really used it, and I have absolutely no experience with it. You look at the duration, it's terrible to titrate. Hydralazine has a very unpredictable effect. So again, these two agents are not great. It's stuff that you'll still hear, but not really useful. So really, those are the tools to use. And really, the clofidipine, esmolol, nitroglycerin are really going to be the ones that are fully titratable and great to use in critical situations. Nitroprusside is titratable, but if you have nitroglycerin, then that's what I would use preferably. I didn't put any dosages because we live in the 21st century, and we have great apps. This is one of them, Easy Drips, and I absolutely adore it. I use it frequently, and I highly recommend that you all use it. Okay, now I'm getting some questions, and I've been ignoring you guys. I'm very sorry. So I'm going to take a minute to look at the chat and answer questions because I'm not used to doing this. Okay, so with regards to investigations, the question from Monica with renal dysfunction and Annalie to do an EKG. You can, it's like you commented, it's cheap and quick. I perfectly agree. And that's where, but you know, we know from very large studies that no significant bad outcomes happen to these patients that are asymptomatic. So, I mean, it's up to you. I think the most important is going to be the follow-up. These patients can't just go into the ether and not get any follow-up, where these things will eventually be picked up. Now, obviously, if follow-up is a problem, then maybe that's when I would consider doing some of these cheap and easy investigations just to get maybe things started and maybe help out whoever is going to do the temporary follow-up. But again, there's no right or wrong answer. You're protected either way. Use catapress. I'm not sure what that is. Maybe. Well, lots of conversation. This is fun. Yeah, clonidine. It depends. Clonidine, I've used it in ICU mostly for patients that are kind of coming off of their Precedex, dexmedetomidine, and really benefited from it and find you want to get a little bit of the blood pressure control, but also maybe a little bit of not sedation, but kind of like anxiolysis, I guess. So I use clonidine in that spectrum. The clonidine at home can be kind of annoying in a sense because patients who are on clonidine at home and go into withdrawal can go into really, really bad hypertensive crisis. So not the biggest fan of clonidine at home. I've never really used clonidine that much as like as a titratable agent or as an agent to use in a hypertensive crisis. With the agents that I just mentioned, you'll be able to cover the grand majority of issues, and then for other, like for specific management, specific cases, they will treat with calcium channel blockers, beta blockers, and nitroglycerin. Any other questions?
Ollie, just so you know, you have left.
Sorry, I didn't hear you.
Just so you know, you have just a few minutes left.
Few minutes. What's a few minutes? Is that 1 or 20?
You have 5 max.
5 max, sounds good. All right, so we'll go into management, which is good because it's the last part of my talk. Again, what are we aiming for? So I kind of divided into, every critical hypertension, and then certain conditions that require very specific management in specific conditions. The 2017 AHA guidelines talk about reducing your blood pressure by a max of 25% over the first hour. Where does that come from? It's basically that if you remember your autoregulation curve, yay, the cerebral vasculature maintains a steady perfusion through a range of MAP, right? The thought is that the lower inflection point on the autoregulation curve is the point that's the point where the brain becomes hyperperfused. That point is 25% below your steady state MAP, whatever that MAP is, right? So they say if you reduce it by 25, you're going to be at the lower inflection point, and then you'll become hypoperfused. But that doesn't really, that works in a steady state. But when these patients come into the Emerg with their blood pressure sky high and organ injury, they're not in their steady state. So I don't see how their lower inflection point is 25% away from where they are right now in the Emerg. Because we don't know where their autoregulation curve is and where they are on that when they come into the Emerg. So it's a class 1 recommendation, fine, but it's an expert opinion. And basically what I mean is, these patients require a rapid MAP decrease in the first hour, no doubt about it. You should titrate therapy to the patient's symptoms. So if it's 10% of their incoming, their initial MAP, then great. But some may need more than 25%. And there are some studies looking at, I forget which one it was, but it was mostly in cardiac patients, that they did very well with a decrease in 30 and 40% decrease in MAP with no significant negative outcomes. Once you've reached that target in 1 hour, you continue to reduce progressively over the next 2 to 6. The AHA target mentioned basically an equivalent MAP of 120. And then after that, over the next couple of days, you continue reducing and try to smooth them into a relatively normal hypertension. So that was for the general management, the targets to reach. As far as the medications to use, nitro is great for basically your cardiac patients. Beta blockers maybe to be avoided a little bit because they'll decrease your cardiac output. And then for everything else, it's whatever you're comfortable with, to be honest. There are no studies that shows one is better than the other. Aortic dissection is basically decreasing the DPDT, basically the shearing force, right? The whole point is to, laser pointer, decrease the height of the pressure wave and try to spread it over a longer period of time, right? It's decreasing the acceleration of each pressure wave so as not to further the dissecting injury. So we have to decrease the heart rate, we have to decrease the stroke volume, and we have to decrease the systemic vascular resistance. So the greatest combo is going to be beta blockers and vasodilators. Here, the specific goals are much shorter. We really need to act very fast and try to decrease the heart rate first, and then eventually your systolic blood pressure in the areas of really closer to 100. And so that's best done with beta blockers and vasodilators, right? And you'll see on the graph there how it impacts that DPDT. Right, don't forget pain control. These patients are in a lot of pain and it has a very high adrenergic drive. So pain control for these patients quite a lot. Brain bleeds. Basically, most of our knowledge of blood pressure control in these patients comes from 2 trials, the Interact 2 and the Attach 2 trials. And basically, we sum it up by saying that we should aim roughly at 140 in an hour. That was the trial design, although it wasn't really followed that well during the trial. So our best guess is that that's what we should aim for, to reduce the bleed, but also to make sure that the patient's still well perfused. The best or I shouldn't say the best, but the most studied drug in this population is nicardipine. But apart from the vasodilators, I'm sure others would be okay as well. There's no paper that says that you can't use beta blockers, although theoretically it could maybe hyperperfuse them, but you have your patient in front of you and you have your institution with the drugs available to you. You have to make a decision. For subarachnoids, the guidelines aren't super clear. They kind of hint at aiming towards 160, but there's no clear target to reach from the stroke guidelines. In the 2017 guidelines, again, well, and then there's the recent ICAS 3 reanalysis, which maybe will get us away from using TPA. But if you are going to use TPA in stroke patients, your targets before you use the drug should be, you have to treat if they're over 185, over 110, and then maintain them 5 below that for the next 24 hours. If you don't use TPA, then just make sure that they're not above 220 over 120, and you aim for a 15% reduction. Again, nicardipine and labetalol used more frequently, and avoiding nitric oxide donors in those situations. For the patients that are kind of in between, data says that those patients weren't harmed by very high blood pressures, and maybe it helped them perfuse their brain a little bit better. So you leave them at that. Preeclampsia, from guidelines from 2 years ago, they use a bit different drugs because it needs to be compatible with the fetus. So nifedipine is a good drug to titrate up. It's an oral agent, so obviously in your patients that are confused or seizing, then maybe not the greatest, in which case I would go for labetalol and then just basically titrate up bolus doses. Hydralazine, again, unpredictable drug, I would stay away from it. And then your second line agents, of all of those, much bigger fan of nitroglycerin if I'm in a rut, and then maybe consider labetalol if I wasn't using that initially. Your goals is basically to stay under 160 over 110 for your severe, but you still treat your non-severe preeclamptic or non-severe hypertensive pregnant patients anyways, and that's at a goal of 140. So basically treat the severe ones and call your friendly OB gynecologist to figure out what your targets are going to be in your institution. A lot of people think of magnesium as a blood pressure lowering agent. It is as a vasodilator in a sense, but that's not why it's used in this situation. Here it's really to prevent cerebral ischemia and seizures. It's just an added bonus that it drops BP, but I wouldn't use it as a BP lowering agent first and foremost. Voila. Take home messages that you can all read, and glad to be back. Questions, comments, insults?
Great, thanks very much, Olivier. If nobody has any more questions on the side, doesn't look like it. Thanks very much. We can move on to our last talk of the day, which is Ahmed, who will be presenting his grand rounds. Thanks very much again, Ali.
I can't really share my screen. Ollie, if you can stop sharing your screen, please. All right. So I know that we were busy fighting and reading about COVID the past few months. And during that time, there was a good amount of non-COVID emergency medicine literature. So that was the reason behind my talk today. Hello, everyone. My name is Ahmed, and I am a PGY4. I have 4 objectives for you today. Number 1, to summarize 6 recent articles within the last 6 months that is relevant to ED practice. Number 2 is to go home at least with the 3 pieces of knowledge that might change your practice in your next shift. Number 3, each article will cover a different system in the human body. So one will be for GI, one will be for cardiac, and etc. And finally, my last objective for today is to give you a potential ideas about for upcoming journal club about articles that you might want to dissect and talk more about. So this will be a case-based presentation. We will start with our first case for today. I will give you 1 minute to read the case and try to answer it. So to answer that question, we have our first article for today, which was published almost 4 months ago in a hemodynamically stable patient with high risk of upper GI bleed. Is endoscopy performed within 6 hours or endoscopy performed between 6 to 24 hours improve outcome? To summarize this article, I will use a PICO style. They, for the inclusion criteria, they included any patient above 18 who will exhibit signs of upper GI bleed like hematemesis or melena or both. And they used the Glidescope for bleeding score for that with the score of a 12 and more. And as we know, if it was more than 6, there's like a high risk patient that might need 50% intervention. And they used a really high score to include a high risk upper GI bleed patient. And they excluded any patient that was not able to provide a consent or was less than 18 or pregnant or had any terminal illnesses. Also, they excluded any patient they were not able to resuscitate and he was in hypotensive shock. In the intervention group, they called it the urgent group, which was the group that had an endoscopy within 6 hours. And that group received also a standard of care of PPI, vasoactive drugs, and IV antibiotic in patients that they might suspect a varicose bleeding. On the other arm, they called it the early endoscopic group, which was the group that received endoscopy between 6 to 24 hours, and they also received a similar standard of care. Their primary outcome was to measure the death from any cause within 30 days, and they had like several points for the secondary outcome. One of them was to see the endoscopic therapy at the first time, or if they will require further endoscopic treatment, or if they will have any further bleeding, and the length of stay in the hospital or the ICU, and if those participants will receive any blood transfusion or any surgical intervention. Also, they measure any adverse events during the 30 days after the randomization. So basically, they had screen patient between 2012 and 2018, and they had more than 4,000 patients. From those participants, the patients who was having a GPS score of a 12 or more was 598. And for those participants who fulfilled the full criteria was 516. They randomized them in a ratio of 1:1. In the urgent group with the patients was like 258 patients. 3 of them, they didn't receive any endoscopy due to several reasons, and 6 of them, they received the endoscopy after the 6-hour period. On the other group, which was the early group, it was similar number with 258 participants, but 5 of them, they didn't receive endoscopy, and 3 of them, they received the endoscopy after the 24-hour periods. What's interesting in this group that 20 patients or 20 participants, they had an emergency endoscopy. They didn't wait for the 6 to 24 hour because they had symptoms that necessitate an emergent endoscopy, which is 8% from the participant. Now, we can see from this table that they shared almost a similar baseline characteristic, but in the urgent endoscopy group, we can notice that they have more coexisting disease than the early group. And the reason behind the upper GI bleed was in both the group, actually almost 62% in both the group was the peptic ulcer. And there was a small number of participants who had a varicose bleed as a reason for their upper GI bleed. Now, for the primary outcome, we can see that there was no big difference, or it was not statistically significant. In the urgent group, the death from any cause within 30 days was 8.9%, and in the early group, it was 6.6%. And also, if those patients will have any further bleeding within 30 days, we can see it was 10.9% in the urgent group and 7.8% in the early group. Also, we can see that there was no difference in the rate of ICU admission, transfusion, or any surgical treatment between the two groups. Now, regarding the timing of endoscopy, if you can notice, they reported that the time of endoscopy from the consultation was actually less than 6 hours in urgent group with 97.6%, which was a great, and also in the early group it was between the 6 to 24 hour with good number. But if you will have the timing of endoscopy from the presentation till they receive the endoscopy, which matters to us as an emergency, in the urgent group, which the patient supposed to receive the endoscopy within the 6 hours, we can see that 48% of them, they received the endoscopy after the 6-hour period. Now, what I like about this article, that it was an RCT, they asked an important question with outcome. They used a validated score, and actually they not even went with the 6, they went with the 12 in their score to make sure that they will involve a higher risk patients with upper GI bleed. On the other hand, there was some limitation. As I mentioned, 48% in the urgent group, they received the endoscopy after the 6 hours from their presentation. Also, their comorbid condition was more in the urgent group, and the number of varicose bleeding was less in both the groups, which might not be applicable in other centers. Now, the author concluded from this study that in a hemodynamically stable patient with a high risk of upper GI bleed, endoscopy performed within 6 hours does not actually correlate with lower mortality rate in 30 days compared to the one that will receive the endoscopy between 6 to 24 hours. The take-home points from this article that patients with upper GI bleed can really deteriorate really fast. As we can see, 8% from the participants, they received an emergent endoscopy. That's why all of your upper GI bleed patient will need an immediate GI consult. Now, if the patient is unstable, they will need a resuscitation and immediate endoscopy. But we can argue that if this patient is a high risk of upper GI bleed, we can consider ICU admission with endoscopy as soon as possible. I think we need more studies to evaluate the timing of endoscopy and we can extend the period from 2 to 6 or from 12 to 24 hours in future studies. Now we will move to our second case for today, and I will give you 1 minute to read the case and try to answer it. I can't really see the chat. I don't know how to do that. Okay. Okay, so I have to close it. Okay, so there has been an extensive debate in how to treat acute atrial fibrillation. There's like two schools, one with the rhythm control and the other schools like for the rate control. The group that suggests rhythm control in acute atrial fibrillation, they argue that acute atrial fibrillation is an abnormal rhythm that might lead to heart remodeling, and those patients might need rate control medication, they might need anticoagulation, and that will basically change the lifestyle of those patients. And the group that argue on those patients we should do rate control and we don't do a rhythm control argue that even if it was an acute atrial fibrillation in less than 48 hours, there is a risk of thromboembolic events on those patients. So we shouldn't attempt rhythm control unless we make sure there is no thrombus in the left atrium by a TEE, or those patients received anticoagulation for a reasonable time. Now, to answer this question, there was this study which was published in 2017 looking for the adverse event in emergency department treating acute atrial fibrillation in a more aggressive approach with a rhythm control, and they found that rhythm control in acute atrial fibrillation is actually safe and effective. So let's say that you chose to go with the rhythm control. Is doing electrical cardioversion better or doing a chemical cardioversion is better? So to answer that question, we have this study which was published, I think last February by Ian Steele in The Lancet, and it involved 11 academic emergency departments across Canada. And basically their inclusion criteria was any hemodynamically stable patient with a primary acute atrial fibrillation lasting more than 3 hours and less than 48 hours. Also, if those patients had their atrial fibrillation within 7 days and they were on anticoagulation medication for at least 4 weeks, or it was within 7 days and they had a negative TEE. Of course, those patients should be symptomatic enough to receive the treatment, and cardioversion was an appropriate option. They had also several exclusion criteria. We can see them like if they were not able to give a consent, or if they were having a permanent atrial fibrillation, and of course, if they were unstable, and if there was any primary cause for this presentation. Also, if they will have any chronic diseases, for example, CHF, end-stage liver disease, pregnancy, MI, or if they will have any arrhythmias like Brugada, or of those patients on any class of antiarrhythmic medication like 1 or 3 other than amiodarone, or if they will be hypersensitive to procainamide. So what they did was basically they included in their, like after those participants fulfill the criteria, they had 396 patients. They did two protocols. In protocol number 1, they had a randomization of drug shock group and shock only group. In the drug shock group, they received IV proconamide, and in the shock only group, they received the placebo. And for those patients who didn't convert it to normal sinus rhythm, which was 296 in this study, they did a second protocol for randomization to involve the electrical cardioversion, where they divided them into two groups, one to receive anterolateral cardioversion and the other group to receive anterior-posterior cardioversion. Now, in the second pool, when they will have no success in cardioversion to normal sinus rhythm, they will use a rate control approach, and they will send the patient home with oral anticoagulation and oral rate medication. Now, their primary outcome to see the conversion to normal sinus rhythm for at least 30 minutes. And the secondary outcome was to check the rhythm at disposition, the length of stay in the emergency, and if there was any adverse event. As we can see, they screened more than 11,000 patients, and they had 396 patients who were enrolled in the protocol number 1, and they divided them into two equal groups. And then, as we discussed in the previous slide, they had the second protocol for the second randomization, and also they divided them in an almost equal groups. Now, for the primary outcome, the conversion to normal sinus rhythm, we can see that there was no difference between the chemical or the electrical cardioversion, with a 96% in the drug group and 92% in the shock only group. And the total length of stay in the emergency was almost equal, with a 7.1 hour in the first group and 7.6 in the second group. And for those patients who were discharged home, they were on normal sinus rhythm in both the group, with 97% and 95% in the shock group. Also, for the second randomization, comparing the anterolateral approach with the anterior-posterior approach for the chemical, for the electrical cardioversion, it was similar in both the group, with 94% and 92%. And as we can see from the first shock, in the anterolateral, it was 88%, and in the anterior-posterior group, it was 81%. Now, there was no serious adverse event in both the group, and in 14 days follow-up, 95% were on normal sinus rhythm. But as we can see in the infusion group, there was more adverse event, and it was mainly the transient hypotension. And in the electrical cardioversion group, it was more related to the procedural sedation with the hypoxia. What I like about this study, that there was a good blinding with important question and outcome, and there was no loss of follow-up, and they had almost like balanced the group between each, like in the two randomization. On the other hand, there was some limitation. For example, 582 patients or participants refused to participate because they were afraid sometimes from the electrical cardioversion. So that's why we had a higher rate. Also, they used only one medication, which was the proconamide. And lastly, the thromboembolic events are usually a rare thing to happen, even with the cardioversion. That's why I think they might need a larger sample to decide who will not need and who will need anticoagulation. The author concluded at the end that both the electrical and the chemical strategy or approach to cardiovert acute atrial fibrillation is highly effective and safe in the emergency department, and we should consider the drug infusion, if we were thinking like this, those patient is a high risk in procedural sedation. And there was no significant difference between the anterolateral or the anterior posterior approach in electrical cardioversion in acute atrial fibrillation. Our take-home points from this article that rhythm control is a safe and effective way in primary acute atrial fibrillation, and there is no difference between the electrical and pharmacological approach. And always, always, always remember your CHADS 65 score for those patients who will need anticoagulation and looking for the cause for the acute atrial fibrillation. Now we will move to our third case for today. And again, I will give you 1 minute to read the case and try to answer it. So now we will move to our third article for today, which was published last January, looking at is a conservative treatment is a conservative treatment and a good alternative for the interventional approach in treating uncomplicated, moderate to large primary spontaneous pneumothorax. And the inclusion criteria in this article was any patient between 14 to 50 years, and if they will have their first episode of unilateral spontaneous pneumothorax with more than 32%. And they used the column method to calculate the pneumothorax, as you can see from the graph. And also they excluded any patient that will have a similar spontaneous pneumothorax on the same side previously, or any patient who will have any bilateral pneumothorax, any patient who will have tension pneumothorax or secondary pneumothorax, and if there was any hemothorax, and if the patient was pregnant, and if the patient will have any travel within 12 weeks, or they cannot continue with the study as in a follow-up. So in the intervention group, what they did was basically, if they confirmed that there was a pneumothorax more than 32%, they will put a chest tube and underwater seal with no suction. And then they will repeat the chest x-ray in 1 hour. If there was no re-expansion and no leak, they will close the drain and they will wait for 4 hours and repeat the chest x-ray. If the patient improved and there was no recurrence of pneumothorax, they will remove it and discharge the patient. And if not, they will open the seal and admit the patient. And of course, all the patient will receive a standard care of oxygen and analgesia in both the group. And as we can see from the other group, what they did was basically they will do an observation for 4 hours and they will repeat the chest x-ray. If the patient was walking, sitting well, they will discharge the patient. And they will intervene if the patient is still symptomatic, even with the adequate analgesia, if there was a chest pain with the mobilization, if the patient was unwilling to continue, and if the patient was hemodynamically unstable, and finally, if the repeated chest x-ray showed enlargement of the pneumothorax. Now, their primary outcome was to look at the re-expansion within 8 weeks, and they had good several secondary outcomes to see, for example, the time of the resolution for the symptoms and in chest x-ray, if there will be any recurrence within 24 hours, if they will use a chest tube, the length of stay in the hospital, and the number of invasive procedures that they will use, and patient satisfaction and adverse events. Now, this was a multi-center study that was done in Australia and in New Zealand. They involved 38 hospitals with a mean age of participants of 26 and a pneumothorax average of 65% and more. They had more than 2,600 patients, and those participants who fulfilled the criteria was 316. They divided them in 154 participants who will receive a chest tube and 162 patients who will have the conservative approach. Now, as I said, the primary outcome was to look at the re-expansion within 8 weeks. This was a non-inferiority trial, and in the intervention group, they had 98.5% success in chest tube, and in the conservative group, they had 94.4%. Now, there was a lot of data missing in the follow-up, so they used the worst case scenario where they assumed the worst happened to those patients that they lost the follow-up with them. So they recalculate the percentage, and they had 93.5% in the intervention group, and in the conservative group they had 82.5%, which was not within the margin. Now, for the adverse event, we can see that it was less in the conservative group, with less length of stay, with less days off work in the conservative group. What was interesting that the patient satisfaction was actually equal in both the group. I don't know why was that, but it was reported as an equal between the intervention and the conservative group. I thought it would be more satisfactory for patients if they will not receive any invasive chest tube. Now, what I like about this study, again, it was an RCT with important question and outcome. It was multi-center, and they used a worst case analysis to compensate for the loss of follow-up. On the other hand, there was some limitation. It was an unblinded study. They used unusual protocol for intervention for the chest tube. And 15% in the conservative group, they went for intervention at the end because, as I mentioned, there was like 5 criteria on those patients in the conservative group that will need that they needed to intervene, and they had a 90 patient that they lost follow-up. Now, the author concluded, though, with the worst case scenario analysis, it was not within the margin. The author still concluded that the conservative management is an acceptable approach in moderate to large spontaneous primary pneumothorax with a lower risk of serious adverse event. Our take-home points from this article, I think we should think about it, but we need more study to say conservative is a good alternative to invasive approach in moderate to large pneumothorax. Now we will move to our 4th case for today. I will give you 1 minute to read the case and try to answer it. So to answer that question, we have this article, which was studying the effect of IV Halidol 2.5 milligram in acute benign headache as a first-line treatment, and their inclusion criteria was any patient between 13 to 55 who will have a history of headache or migraine, and they excluded any patient that they thought it could be a secondary reason for the headache, and if the patient was pregnant, if they will require a CT, if they will have a high blood pressure, or if they will have a QT more than 450, or they were an allergic to Halidol. Now, in the intervention group, as I said, it was a low dose Halidol with 2.5 milligram IV. And in the control group, it was placebo. Their primary outcome to see the change in the headache score, in VAS score, as we can see, at 30, 60, 90, and at discharge. For the secondary outcome, they were looking at the time for the pain relief, the degree of pain relief in VAS score, any side effects or any change in QT segment. Now, this was a single center study. They involved 287 participants, and those who fulfilled the criteria was 118. They divided them to two groups. One will receive a placebo with 60 participants, and 58 will receive Halidol. If there was no if there was no 50% reduction in the VAS score at 60 minutes, those patients will receive rescue medication like ketorolac and Maxiran. And the author defined the resolution of headache by having a VAS score of 0 or 1 at 30, 60, 90 minutes, and at discharge. And they will have also a follow-up call the next day. Now, as we can see, most participants were female in both groups, and they had less participants between the age 13 to 17. And most of those participants, with 59% and 59% were having a history of migraine. The reported number of VAS score was 90% of those participants were having a headache with a VAS score of 7 or greater. Now, the 50% reduction in the Halidol group was 34% at 30 minutes and 11% in the control group. And at 60 minutes, it was 63.8 in the Halidol group and 21% in the control group. For the adverse events, it was mainly an anxiety and restlessness in both the group. And the QT change was not statistically significant. There was no statistical significant difference in QT changes in both groups. Now, what I like about this study, that it's the first and the largest blinded RCT that was done to address this subject. They had a good follow-up. The problem that it was a small sample size. They had more female and less patients, though they said it's like from 13 to 55, the patients or participants between 13 and 17 were less. The history of migraine, though it was like reported in a high number, they didn't detail it. They didn't say it's like how frequent they will have their migraine, what medication they were taking, how frequently they will visit their neurologist for that. And those patients who will have a resolution of headache within 60 minutes, they will not continue with the study and they will not wait for 90 minutes. The author concluded that the low dose Halidol with 2.5 milligram is an effective treatment for patients between 18 and 55, and they will need more studies to see the effect in the younger age group. Our take-home points from this article that it's safe and effective first-line agent to treat benign headache in adults, and the ECG might not be necessary even to do before administering the medication, as there was no significant patients that received Halidol had any QT changes. And we should think about it as an alternative solution or in refractory cases. Now we will move to our 5th case for today. And again, I will give you 1 minute to read the case and try to answer it. Okay, so the amazing trial, which was published in 2017, was looking for the post-contrast acute kidney injury in patients with chronic kidney disease stage 3 by comparing if you will give no hydration or if you will give a hydration with a normal saline. And they concluded that giving no hydration is actually non-inferior to giving a hydration with normal saline, with 2.7 and 2.6 in both the group, causing post-contrast acute kidney injury. Our case for today, our article for today is the COMPASS trial, looking at the post-contrast acute kidney injury in patient with chronic kidney disease stage 3 who will not receive any hydration, and the other group who will receive sodium bicarbonate as a pre-hydration. And their inclusion criteria, they included any patient with stage 3B chronic kidney disease, and any patient with stage 3A and will have diabetes, or any one of the two that you can see listed. And they excluded any patient with a chronic kidney disease who's like less than stage 3, pregnant, less than 18, had any allergy to contrast, and if they had any kidney transplant within the last 3 years, or the patient was hemodynamically not stable. This was a study for an elective contrast CT scan. So if the patient will have any CT that is scheduled to happen within 7 days, or if he will have, or if he had a CT contrast, CT with contrast within the last 5 days, they will exclude that participant from the study. In the intervention group, they did a prehydration with sodium bicarb, and in the other group, they didn't do any prehydration. Their primary outcome was to look for the mean relative increase in serum creat in 2 to 5 days. And for the secondary outcome, they were looking for the incidence of post-contrast acute kidney injury, and they defined it as having a creat with increase more than 25%, or if there was increase with 0.5 milligram per deciliter. Also, they were looking for the relative increase in creat in 7 to 14 days, and the recovery of the renal function in 2 months, and if there was any incidence of heart failure and the total health cost. Now, this was a randomized clinical trial done in 6 hospitals in Netherlands. They had 554 participants, divided them into 2 groups with 276 in the hydration group and 278 in the sodium bicarb group. For their primary outcome, The relative increase in creat in the prehydration group was 10.5%, and in the sodium bicarbonate was 2.3%, which was not statistically significant. There was no statistical significant difference. And for the secondary outcome, as we can see, the post-contrast acute kidney injury was reported with 2.7 in the no prehydration group and 1.5 in the sodium bicarbonate group. As we can see that 43% in the no prehydration group had a renal recovery in 2 months, and 50% had a renal recovery in 2 months in the sodium bicarbonate group. And there was no incident of heart failure reported. Now, what I like about this study that it was a well-done RCT with a few exclusion criteria. They had a good follow-up, and the intervention arm was based on a previous meta-analysis looking at the sodium bicarbonate as an agent to be used as a prehydration in a chronic kidney disease to prevent post-contrast acute kidney injury. The limitation was, it was an elective CT. It was not an emergent and the critical CT, which is what applicable to us in emergency. They didn't use any arterial contrast, and their primary outcome was not patient oriented. They were looking at the elevation in serum creat, the mean increase in the serum creat, but it was not a patient oriented. And of course, they were not able to do it as an unblinded study. The author concluded that in chronic kidney disease patients who will receive a CT scan withholding the prehydration appeared to be safe, and prehydration, not giving any prehydration is safe and cost effective. Our take-home points that in a chronic kidney disease patient, they had an elective CT, so they didn't had any benefit from prehydration, and prehydration can actually increase the adverse event and health cost. So if you're thinking of having an urgent CT scan with contrast for those patients, not giving hydration might be a safe approach, and we will need more studies to evaluate that in emergency department point of view. Now we will move to our last case for today, and I will give you 1 minute to read the case and try to answer it. Okay, so 2 years ago, we had a journal club in a debate style talking about this article. And I was actually against using Marek cocktail for sepsis, which was the hydrocortisone, vitamin C, and thiamine. They suggest that using this cocktail might prevent organ dysfunction in a septic patient. And we concluded that we needed more studies and external validation before applying Marek cocktail to our septic patient. There was 2 studies that was done last year addressing this issue, and both found that Marek cocktail doesn't work. The idea behind Marek cocktail that vitamin C can help with the catecholamine surge, and it can improve the cardiac output and also keep having a good vascular tone. And using a steroid might shorten the length of stay in ICU. And using thiamine will help to reduce the vitamin C metabolism. To answer today's question, we have this article looking at Marek cocktail, if it will improve the mortality in 28 days compared to placebo. And their inclusion criteria, basically any patient with sepsis fulfilling the diagnosis criteria for sepsis 3, older than 18, and at admission in ICU, they will have a procalcitonin level just as an indicator. And they will exclude any patient who is pregnant or who will have any discontinue of a treatment, if he will have any non-infectious factor or persistent infection source that will need elimination by surgery or debridement. Their intervention group was basically the exact Marek cocktail that was used in his original article, as you can see. And in the conversion group, they had placebo. Their primary outcome to see the mortality in 28 days, and they had several points for the secondary outcome. For example, using the duration of using vasopressor, the length of stay in ICU, the change in the SOFA score, and any adverse event related to using Marek cocktail. So this was a single study that was done in China. They screened 159 patients, and they had 80 patients who were enrolled in the randomization, divided them into 2 equal groups, 40 patients who will receive the treatment, and 38 at the end received the treatment. And for the other group who received the placebo, which was 40 patients, they ended up giving the placebo to 12 patients only, because this study was a single-blinded study, and the physician who were administering the placebo thought those patients are at high risk of having pulmonary edema, and they decided not to give the placebo. So the source of infection on those septic patients were mainly from pulmonary infection, 77.5 in the treatment group and 67 in the treatment group. And those patients who received vasopressor were 55% and 60% in the treatment and the control group. And those patients who received mechanical ventilation was 75% in the treatment group and 80% in the control group. And actually, those participants were on a high mortality, like 40 to 50%, as we can see from the SOFA and Apache score that they used and they report. So for the primary outcome, the mortality was 27.5% in the treatment group and 35% in the control group. It was not statistically significant. There was no statistical significant difference. And for the length of stay in the ICU, it was almost equal with a 7.5 in both groups. Now, for the reported adverse event, it was hypernatremia and GI bleed. The hypernatremia was 13 patients in the treatment group. And what I like about this study, that they used the exact cocktail in Marek study. They used the definition in sepsis 3 as an inclusion criteria. The outcome was more patient-oriented, and they didn't have any loss of follow-up. Now, the limitation in this study, there was no clear timing that when they administered that therapy. Is it like in the emergency, in the ICU? It was not really clear. And 13 patients, as I said, had who had the hypernatremia. They didn't continue with the study. They stopped giving the cocktail. And 28 patients, as I said earlier, they didn't receive the placebo because it was a single blinded study. Now, also, they didn't specify what kind of antibiotic or fluid or amount those patients received. The author concluded that giving Maric cocktail compared to placebo that it didn't appear to reduce the mortality. However, they said they will need a larger study to study and validate the effectiveness and the timing of the treatment. Also, they said it's not really harmless and it might cause side effects like having hypernatremia. Our take-home points from this study that Maric cocktail appears to be too good to be true. Now, to summarize, we talked today about 6 non-COVID emergency medicine literature that was published in the last 6 months. And each of them were addressing a different system in the human body, as you can see. And I hope that you will go home with at least 3 pieces of knowledge from those articles. Thank you so much. That's it.
Okay, thanks, Ahmed, for talking a little bit about something non-COVID. Hopefully that starts a good primer for people to start looking to the literature, because we have some journal clubs coming up as well. So thanks very much. It must have been a lot of work to go through 6 different articles, so thanks.
My aim was to do 10, but I couldn't.
If you want to do more, there's always room in the schedule, so we're more than happy to have you back. Just a reminder to everybody else, if you haven't signed up for Journal Club or for Grand Rounds, then please do so. I can send the link out and I'll be messaging people who haven't signed up yet. And if anybody else has any questions, I think Dr. Chimrani is asking for a summary sheet with the links for each article and main take-home points, if you would be so kind, Ahmed. You will have access to the recording. I just have to upload it and figure out how we're going to post it. The beginning of the recording was cut off a little bit. I started a little bit late, but the entire thing has been recorded, so you can refer back to it if need be. That's it. Thanks, everybody.